speech and swallow therapist, currently working at Nepal Medicity and at Nepal Cancer Hospital. The topic that I'll be touching on today is neurogenic dysphagia and approaches to it. My work has been made easy with input from Sara and Prabha ma'am. Thank you so much. I will not be going into detail about the stages of swallowing and everything because I think everything has been covered. I just want to show a video on video fluoroscopy swallowing study. This is the lateral plane, and the patient is asked to swallow a pill. You can see that the pill has moved on to the from the oropharynx to the pharyngeal stage. The patient takes a little bit of contrast, liquid contrast, and the pill goes down to the esophagus. So this is a normal swallow study. So on average, we swallow about 580 times a day. So we can imagine how effortless it is for a normal being. Now, because the topic is on neurogenic dysphagia, I would like to highlight on the 17 physiologic components, which this will be later helpful because I will also be discussing on impairment-based therapy intervention that can be given. So initially, the swallow starts with lip closure, and with good control, the bolus is transported. And without oral residue, initiation of pharyngeal swallow happens. The soft palate is elevated, the laryngeal elevation happens, anterior hyoid excursion, and the epiglottic movement, that is the epiglottic inversion. Laryngeal vestibule closure happens, pharyngeal stripping rate, pharyngeal contraction happens, resulting in pharyngeal clearing. Pharyngoesophageal segment opens, tongue-based retraction, and the esophageal clearance. Now moving on, the neural control of swallowing. Out of the 12 cranial nerves, the most important for swallowing are these 5. So in the cranial nerve examination that we carry out during the clinical swallow evaluation, if not all the cranial nerves, at least these 5 should be not missed out. So those include the trigeminal nerve, facial, glossopharyngeal, vagus, and the hypoglossal nerve. Now all the 5 nerves innervates the 32 pair of swallowing muscles. These muscles give afferent and efferent input, which is mediated in the brainstem that has a central pattern generator. Organization and sensory and motor organization happens here, and then the information is sent to the cerebral cortex. Now, what is neurogenic dysphagia? Swallowing disorders caused by disease of the central nervous system, peripheral, neuromuscular transmission, or muscles. These comprise our neurogenic dysphagia. Now, how common is dysphagia in these cases? 50% of all patients with ischemic or hemorrhagic stroke, TBI with incidence of clinically relevant dysphagia in about 60% of patients. 20 to 30% of patients with dysphagia have dementia have severe dysphagia with silent aspiration. Clinically, all ALS develop dysphagia as disease progresses. 1/3 of patients admitted to stroke rehabilitation unit. Dysphagia occurs in 29 to 64% of all the stroke patients. These data, unfortunately, are not from studies carried out in Nepal. These are from international journals. Now, what is the negative sequel of dysphagia? We all are aware of it. The dysphagia this cycle forms a vicious cycle. Aspiration pneumonia leads to immunocompromise, leading to increased risk of aspiration and infection, increased risk of skin breakdown, poor wound healing, malnutrition, and dehydration. And when there is all this, muscle breakdown happens, which in turn leads to swallowing difficulty. We all are aware of the signs and symptoms. These range from changes in eating and drinking behavior, avoidance of certain food and consistency, difficulty in taking food, difficulty in taking medication, increased time needed for a meal, posture during eating, difficulties with chewing, food residue in the mouth or the throat, and often patient complain of food stuck on the throat, globus sensation, voice change, throat clearing, coughing or shortness of breath during meal or shortly after that, oral or nasal regurgitation of the bolus. Now moving on, roadmap to dysphagia. dysphagia. So this is just a basic idea on how we approach every neurological cases. First, we diagnose the dysphagia and then we manage. But in between, because often diagnosis and management might take time, we also have to keep into consideration the alternative feeding method. On acute onset of dysphagia, I think we are already at the worst, so it only gets better. But in progressive cases, at the time of assessment, maybe the patient is at his best, and then slowly it will gradually get worse. So while approaching a patient with progressive disorder, it's more like shooting a bullet in the dark. Like you just go with the flow. Whatever complaint the patient has, you deal with it, and then you diagnose it accordingly, and then you manage it accordingly. But in case of acute, it will always get better. Whatever the approach may be, the main goal is to ensure swallow safety and swallow efficacy. Onto the diagnosis, the first step will be our clinical swallow evaluation. We all are aware, and I think all of us perform this religiously, the clinical swallow evaluation. Out of all the things that we perform clinically, I think these are the main things that we should not miss. We have to keep into consideration the cognitive status of the patient. GCS, usually more than 10 or 11 is considered safe for swallowing, and oral hygiene, SARA has put enough effort to highlight its importance. And the cranial nerve examination, the blue dye tests used in case of tracheostomy, cervical and chest auscultation, pulse oximeter, especially sensitive in the case of pediatrics rather than adults. The water swallow test, washing the active swallow, and then the use of standardized tool such as GUS or E10. Now, based on the information from the clinical swallow evaluation, we can divide the patients into 3 groups: those who are fit for oral feeds, those who are unfit for oral feeds, and those patients on which the possibility of aspiration cannot be ruled out, patients on the grey line. For the second and third group, that is the patients on whom aspiration cannot be ruled out and on whom we are not sure, we have to carry out the instrumental evaluation. Now, the gold standard, I would say, in today's time is both fluoroscopy and flexible endoscopy. You cannot weigh this better than that. I think both complement each other rather. So I have put it's the same video. So this is usually helpful to assess the oral phase dysfunction, esophageal phase dysfunction, and in cases where you have doubtful aspiration on fees. Next would be fees. We carry out on those patients on whom we have we suspect pharyngeal dysfunction, anatomical diagnosis, saliva aspiration, and often to see the site of disease. You can see the NG tube passing through the right piriform sinus. There's pooling of food in the post-cricoid area. The right vocal cord looks fixed, if I'm not wrong. So this is the video piece. Now the advantage of one over the other. Fees, like I said before, addresses the pharyngeal stage before, during, and after the swallow, primarily from the superior view. VFS we can view in the lateral mainly and also in the AP view. This gives an idea on oral pharyngeal and cervical esophageal stages. Fees can be performed at bedside, whereas fluoroscopy you need a special suit. Fees can be performed on patients. Fees cannot be performed on patients with craniofacial trauma, brain trauma, confusion, and agitated or comatose patients. Whereas fluoro, you can take the patient with a ventilator, and then you can transport the patient from the ICU to the fluoroscopy suite and perform it. after you've done the clinical swallow evaluation and then the instrumental evaluation, and like I said, since management might take from days to weeks to months, you have to think about the alternate feeding method. So our main input that we can give as an SLP would be either to suggest for NG tube or PEG. Again, this is not solely our decision. This has to be discussed with the neurological team, and then we decide it. NG tube is usually recommended for short term around 1 month, and then PEG more than a month. Now coming to the management of swallowing disorders, basically you can classify it into two groups, that is indirect and direct swallowing disorders, swallowing therapy, and then the third will be intervention, that is surgery. Direct swallow therapy involves no food. It includes all our strengthening exercises. That includes our maneuvers, strengthening of the lip, palate, suprahyoid muscles, tongue muscles, laryngeal and pharyngeal muscles, and our NMES, neuromuscular electrical stimulation. And direct swallowing therapy, food is given. This includes all our positioning and postural change. We can change the timing of our food intake, temperature, texture, tilt, and techniques. Time frequency, like on patients who have fatigue, you often have to plan small but frequent meals. And also, like Dr. Rajiv stated, like we have something known as on and off stage. So usually on patients with Parkinson's, we can plan our meal in such a way that after the medication is taken and while the patient is on the on stage, the swallowing is better. We can time it that way. Texture, liquids for cases with stenosis, tongue weakness and pharyngeal weakness is always better. Semi-solid is generally used for laryngeal incompetence and pharyngeal spasm. Temperature, warm bolus is always better for muscle spasm. Cold is used for reduced sensation, reduced gag, or when there is oral apraxia. Tilt, we ask the patient to tilt in such a way that gravity allows the bolus to go through the normal side while we close down the weaker side. Techniques such as Mendelssohn, supraglottic swallow, supraglottic swallow, Masaku, and effortful, and chin tuck are used. So this is the I've highlighted on the clinical swallow evaluation and on the instrumental evaluation and on the general idea on the therapy. Now coming on to first slide that I stated, the 17 impairment. I will briefly put videos and photos of whatever data I have, and then we can discuss on what compensatory or rehabilitative or surgical, if possible, approaches that can be applied. So first will be poor lip seal. So any inputs on what compensation can be done? Anybody? For poor lip seal. Sorry?
Muscle strengthening exercises.
That will come under rehabilitative. Compensatory.
We want maneuver.
Yeah, something like that. So if a bolus is drooling down anteriorly, so what do you think will work?
Posterior.
Yes.
Tilt off.
Or maybe you could support the lip.
Tilt.
So compensatory strategy will be straw drinking or labial press or manual support, or you could also change the texture and bolus size. And rehabilitative will be a labial range of motion and, like you said, strengthening button and thread exercise. Now coming to the second impairment, nasal regurgitation. Here you can see a piece. Maybe it's a short one. The bolus is coming up to the nasopharynx. That's the white. That's the bolus. On the fluoroscopy, you can see the contrast going up to the nasopharynx. So for this, any inputs?
Head tilt.
Postural modification, yes, but head back.
Yeah, posture modification.
Yes, correct. So for nasal regurgitation, we have nose pinch, chin tuck, texture and bolus size modification. And rehabilitative will be blowing against resistance exercises that works on your palate and if these don't work, you have intra-oral prosthesis as well. On valvulostasis. For valvulostasis, it's always better to have the patient to protect their tongue so it's better visualized. So for valvulostasis, any inputs? So compensatory strategy will be a suck and swallow, sensory stimulation technique, texture and size bolus modification, chin tuck. In case of residue, we ask the patient to do a head tilt maneuver, multiple swallow, liquid wash or oral sweep. And rehabilitative exercise will be back of tongue exercise, Mosako maneuver, effortful swallow, supraglottic swallow and supraglottic swallow. Now absent hyolaryngeal excursion, often visualized in fees where we do not see the whiteout. Or incomplete whiteout. This suggests that the patient might have absence of laryngopharyngeal paralysis. And often on fluoroscopy, we see poor opening of the upper esophageal sphincter. So to work on hyolaryngeal excursion, any inputs? So the compensatory would be chin tuck, or we can ask the patient to be on the sideline position. And in case of residue, head tilt, multiple swallow, liquid wash. Rehabilitative strategy would be effortful swallow, supraglottic swallow, Mendelssohn maneuver, jaw opening against resistance, chin tuck against resistance, shaker exercise, pitch glides, and EMST. And other strategies would be neuromuscular electrical stimulation. And laryngeal incompetence will be the other impairment. You can see direct aspiration. Incompetence could be bilateral or unilateral. And penetration or aspiration. Here we can see a little bit of contrast going to the laryngeal inlet, that is termed as penetration. And the contrast going beyond the vocal cord, you can see in the anterior trachea, that is the aspiration. So for both penetration and aspiration and unilateral or bilateral laryngeal incompetence, you can use the compensatory strategies such as chin tuck, head tilt, sideline, head turn, also have a maneuver, therapeutic texture modification, modification of bolus size, and rehabilitative, you can use EMST, vocal cord adduction exercise, falsetto, supraglottic swallow, supraglottic swallow, and effortful swallow. Other surgical strategies would be medialization hyaloplasty, injection adenoplasty, and abdominal rotation. Now, other impairment would be cricopharyngeal dysmotility, often seen as impaired relaxation of the upper esophageal sphincter or formation of a cricopharyngeal bar. Relaxation could be absent or present or reduced. This is often seen in cases with medullary stroke and very difficult to treat. And you know that the cricopharyngeal is not relaxing when there's too much pooling in the post-cricoid region. And in cases of lateral medullary syndrome, even though the patient is already on oral feeds, you can still see pooling of saliva. Saliva swallow will be the last to recover in medullary cases. So how do you work on cricopharyngeal spasm? The compensatory strategy would be head tilt, head turn, sideline, texture and bolus size modification, multiple swallow, liquid washout. And often the cricopharyngeal muscle opens up with sour bolus or long bolus, or even with carbonated liquids. Rehabilitative strategy would be effortful swallow, Mendelssohn maneuver, jaw opening against resistance, chin tuck against resistance, and Shika exercise. Often when this does not work, other strategies are kept into consideration. That would be dilatation, Botox injection in case of spasm, cricopharyngeal myotomy, or myectomy. Next would be pharyngeal residue, often seen when the pharyngeal contraction is weak. This is seen with residue in the piriform sinus, that could be unilateral or bilateral. Also in the fluoroscopy, you can see the arrows pointing to the pharyngeal residue. To work on this, you can give the rehabilitative exercise effortful swallow, suprasupraglottic swallow, Mendelssohn maneuver, chin tuck against resistance, and Shika exercise. And other surgical strategies would be neuromuscular electrical stimulation or obliteration of the affected piriform sinus, that would be surgical. I have kept into consideration the basic and from the least difficult to the most difficult impairment to deal with when it comes to dysphagia. To conclude, I would say all the patients, all the cases needs a tailor-made approach. You cannot use a single cookie cutter for all the patients that come with a complaint of dysphagia. Oromotor exercise is the solution to all the impairments. Using thickened liquid does not treat dysphagia. And not all the impairment benefit with chin tuck. Thank you.
So if there is oral and pharyngeal dysphasia both, like weakness is there, lip seal is not there, and then we are suspecting is the aspiration is happening, because in those conditions, what will be the maneuver you will use, like ortho strategy that will be applied first?
Is it only the lip that is affected?
No, oral dysphagia is also there, and then we have pharyngeal also in that condition.
See, even oral phase of swallowing has so many physiologic movements. So first would be your lip seal, and then the tongue sweep, and then the posterior of the tongue has to have the strength to hold the bolus. So first, I think we need to rule out which
it's
particular
like the tongue. We mostly see in the stroke patients, severe patients, that they have weakness in tongue and also in the lips. So movements is not happening, and they are kept in NG2 for a long time. That if we go on do some stimulation also, that will take time. And then they also have pharyngeal dysphagia. So in that condition, what will you first treat, like first kind of actions goes on?
there are evidence that suggests that oral dysphagia alone causes pharyngeal dysphagia. So my first input would be in the oral stage. And also, because I'm privileged enough to have access to fees and fluoroscopy, I think just to initiate swallowing also, I would at least do a scopy or just an NPL and see the secretion management. And if the oral phase is that affected that you cannot introduce bolus in the oral cavity, maybe posterior placement will help. And that is in case the pharynx is intact.
Yeah, if we suspect, like in most of the settings, we don't have instrumental evaluation. So we need to do, if we do a few hour subjective test and we have found that okay, there might be a risk of aspiration, but there is no movement. So will you work with first with the exercises and
Yes,
go
definitely.
with
With oral water, yes.
and then go with the
Yes.
food and
Ms. Mahima, nice presentation. Mine is not a question. You had mentioned in the last line, this one, Chintac is not a solution. I just remembered one of my students, a PhD student, she has recently been awarded. She extensively worked on this Chintac technique, modified Chintac technique. Perhaps, I don't know whether you are aware of it. You can get more information on that to apply it on your clients also. It was particularly on Chintac modified method.
What I meant by that was, I mean, in general practice here, like what we say is with everybody, with all the patients with dysphagia, be it oral or pharyngeal or even esophageal, we are, we are over, how to say, over approaching and then suggesting Chintac to everybody blindly. So my whole point was, you should have some evidence either by a fees or a fluor if possible. And then only go forward and use
You have said very correctly. I am not saying it was wrong. No, I just wanted to add on to that.
and modify it.
Her name is Dr. Sodium Belliappa. It is available on the AISH web portal.
Just adding, like how Mahima said that we need to figure out breakdown in each phase, like oral phase has its own phases and pharyngeal phase has its own phases. So we need to figure out where is actually the problem. Then we can recommend the rehabilitative and compensatory strategies followed with the diet modification also. Diet modification is also, I think, equally important while treating the patient.
So moving on to next, it's my honor to introduce Ms. Nani Showa Shakya, who is the Associate Professor at College of Applied Food and Dairy Technology and is the President of Nepal Dietitian Association and also is working as Senior Dietitian at International Friendship Children Hospital. A specialized training in dietary management from Japan coupled with certification as a diabetes educator and completion of ESPN L courses and several publications in esteemed journal highlights her commitment to staying at the forefront in the field of nutrition and healthcare. So let's extend our warm welcome to share her valuable insights on the role of nutritionist in this space.
So my topic I've chosen is dietitian's perspective in the management of swallowing disorder. This is the outline of my presentation. So everything, many has been explained by our fellow presenters, especially Ms. Dawari. So Prabha Dawari. So we all know that dysphagia is a condition of difficulty in swallowing caused by neurological or structural damage that interferes with the efficient movement of food and fluid from the mouth to stomach. So I do not have to elaborate in this who are already specialized in their field. So as we all know that it can occur in all age groups, but more in all elderly population. And I think soon this may be challenging for all of us because the elderly population is increasing day by day. So it is a common consequence of illness or injury resulting in mechanical or neurological impairment of the swallowing process. So we all know that if we couldn't diagnose timely or identify dysphagia timely and manage timely, malnutrition and dehydration can be a big problem with the patients with dysphagia. So it is one of the increased cause of increased length of hospital stay with poor prognosis and reduced quality of life. about dysphagia epidemiology, it is estimated that it affects about 22% of the world's population more than 50 years of age, and up to 30% of patients in hospitals, and 60% residents in nursing homes, and 14% of people more than 65 years of age living in the community are suffering from dysphagia. So according to the American Speech Language Hearing Association, 1 in 25 adults experience swallowing problems. So and it is estimated that 30% or higher are residing in inpatient care. And research shows that 33% of patients with dysphagia develop pneumonia, and 60,000 individuals die each year from the complication of dysphagia if we couldn't manage properly. So dysphagia is more common among older adults. It is estimated that 68% for residents who are residing in who are having long-term care, and those it is found that 30 to 38% is found in those living independently, and older adults have increased risk for dysphagia related complications, especially the aspirated pneumonia. So who are at risk of dysphagia? So I think we do not have to elaborate on this. So elderly population, because there is a decline in the neurological muscles. So also the patients with neurological problems, as already Dr. Oja has explained, that patients who are suffering from Parkinson's disease are at high risk of dysphagia. And similarly, multiple sclerosis, motor neuron diseases are also at high risk of dysphagia. So similarly, cerebrovascular disease, especially stroke patients, if we couldn't treat them properly, they are at risk of dysphagia. And as Dr. Kunjan has already explained about head and neck cancer, so patients who are suffering from head and neck cancer and esophageal cancer, they are also at high risk of dysphagia. And those patients who have injuries affecting head and neck, and especially now the population with dementia, they are also at rise. So these are the group of population who are at high risk of dysphagia. And sarcopenia or genetic syndrome increases the risk of dysphagia. So what are the consequences of dysphagia? I think the previous speaker, she has already mentioned the vicious cycle of dysphagia. So because of dysphagia, there is inadequate intake of food. So this leads to malnutrition and dehydration, and this causes the aspiration of pneumonia. Again, is a big problem of dysphagia. Similarly, with aspiration pneumonia, because of inadequate intake, it again causes malnutrition and dehydration. And there is a big, with dysphagia, there is choking problem is more, and there is increased risk of infection, chronic lung diseases increase, and with dysphagia, there is increased rehospitalization risk. So also the adults with dysphagia may experience disinterest, embarrassment, and isolation, like we can see that because of the symptoms. So the disinterest, embarrassment, and isolation related to drinking or eating, that worsens quality of life, and this also again leads to inadequate intake, and again this leads to malnutrition and dehydration. So dysphagia and malnutrition, talking about dysphagia and malnutrition is a severe complication of this disease. I think we can see in our day-to-day life in our hospitals. So studies suggest up to 50% individuals with dysphagia are at risk of malnutrition, and 16% are malnutrition. So approximately 3 to 29% of patients suffer from both malnutrition and dysphagia. So not only dysphagia patients are malnourished, but malnutrition again can cause dysphagia. So this is nice diagram where we can explain that dysphagia and malnutrition is interrelated. So the upper part of the figure shows that disease and aging is a positive factor for malnutrition and dysphagia. And so issues in nutritional, the lower part shows that the issues in nutritional care for people with dysphagia again cause malnutrition, and that leads to dysphagia also. So I think we do not have, there are many different nutritional assessment tools globally. We are using that, but there is no gold standard that is specific for dysphagic patients. So due to that, we are not, I think here also in our scenario, do we do a nutritional assessment or screening of our patients? I don't think so. So nutritional, as there is no gold standard for dysphagic patients, we never do nutritional assessment of our patients. That again leads to malnutrition because we cannot diagnose these patients timely. And so as Prabha has already, in her previous lecture explained us the IDDSI framework of diet modification, which again reduce the appetite because people, these texture modified diets are not so palatable, and so this again, due to the unpalatability, they tend to have inadequate intake, that leads to malnutrition. And also we do not have, because of lack of evidence, there is no specific nutrition intervention. This again leads to poor nutritional intake to our patients. So why does malnutrition occur in people with dysphagia? So there's inadequate food and fluid intake following changes to the recommended consistency of food and fluid. As I have mentioned that due to the change in consistency, the food doesn't become very palatable. So people with dysphagia tends to avoid those type of foods. And inadequate provision of nutrition textures modified food and fluid due to lack of proper guidance. And also we can see that with patients with dysphagia, they take longer to eat a meal, which result in loss of interest in eating because they have to chew the food. They take longer time to eat. So so they lost interest in eating, and so again food gets cold. By the time they finish the food gets cold, resulting in unappetizing meal. This also again lead to inadequate intake, and that causes malnutrition. So barriers for eating. There are some of barriers which prevent our dysphagic patients in eating. Some of them are anxiety or depression, often as a consequence of underlying illness. Confusion, because that is a result of stroke or dementia. And because of fear of choking, people tend to avoid having foods. And also difficulties in producing both texture modified foods and fluids to a given standard due to lack of proper guidance. Because we are not, many of our dietitians, I think majority of our dietitians are not trained about this texture modified food. That's why we couldn't produce a standard diet for the dysphagic patients that again lead to aspiration, and that again causes malnutrition. Other barriers are there is lack of elaborative guidance and education. So some foods cannot be successfully pureed to require consistent, smooth texture as explained by the IDDSI framework. And also food stock is not aesthetically acceptable due to poor appearance because most of the foods that are suggested are pureed. So they are not aesthetical, they are not presentable, and color and flavor is not very bland, so the acceptance of this type of food is poor. An inconsistent preparation of pureed foods that prevent the right texture of the finished product increases the risk of aspiration. And also sometimes when we need to dilute the foods, because of lack of information and education, we tend to dilute it with water that hinders to meet the energy and nutrient requirement. So the next problem that we face with dysphagic patients is dehydration. Dehydration is a major concern for patients with dysphagia. Individuals requiring thick fluids have a higher incidence of dehydration due to non-compliance and palatability of thick fluids. A hydration assessment with ongoing monitoring and management of fluid intake is beneficial for preventing the morbidity and mortality risk associated with dehydration. So we collaborate with speech and language therapy for solving this problem with dehydration. The aim is to minimize the risk of dehydration while managing the risk of aspiration. Vocal strategies to reduce the risk of dehydration, because there are different guidelines which says to how to reduce the dehydration. There are the dietary guidelines which is not acceptable to our context. So I think we, along with speech and language therapies, we need to work on that and develop guidelines so that ease the patient to relieve the dehydration, and design education materials and organize classes for the patients and the family. Role of dietitian in the management of dysphagia. Talking about on diagnosis of dysphagia, multidisciplinary dysphagia management team should enroll dietitians. I think we are not involving dietitian in our multidisciplinary team. So that is lacking, and dietitians should work closely with speech and language therapists and vice versa. And the aim of collaborating with speech and language pathologists is to ensure good nutritional status and is to address any nutritional issues found. So how dietitians can help them? So the first and foremost thing we have to do is we should do nutrition screening. On admission of any dysphagic patients in the ward or in hospital, they need to screen the patient for malnutrition. And then if the patient is malnourished, then we have to refer dietitian for the thorough detailed nutritional assessment and make diagnosis. And screen and assess the nutrition that all patients with dysphagia will have validated to. There are many different tools that we can use that is very simple, and not only dietitians, all the healthcare professionals, they can use these tools to screen for malnutrition. So generally we can use mini nutritional assessment short form, which has only 6 questions which we can do it. So this screening tool is designed for the elderly population, and or we can use short nutritional assessment questionnaire. Based on that questionnaire, we can refer the patient. If we found patient malnourished, we can refer the patient to the dietitian and do the detailed assessment. And also we can perform a multidisciplinary assessment of swallowing function and nutritional status and diagnose malnutrition. So there are different tools available to diagnose malnutrition, and lately the most appropriate tool that that is acclaimed by the ESPN and SPN is GLEAN criteria, that is Global Leadership Initiative on Malnutrition, which is simple tool that can be used by any healthcare professionals and diagnose malnutrition, and accordingly we can manage the patient. So these are some of the tools, the format of the tools. This is mini nutritional assessment. It is the short form, and the detailed one we have. There are 14 different questions. So there is 6 different questions. Accordingly, we can score it. And if the score is 0 to 7, in between 0 to 7, the patient is malnourished, and with that we can refer the patient to the dietitian for further management. And this is the Global Leadership Initiative on Malnutrition team format, which has, after doing the risk screening, we can do the diagnostic assessment, diagnosis and severity grading. This takes hardly 10 minutes to perform. So we can use this in our scenario and diagnose the patient with whether they are malnourished or not. So the next the dietitian can do is in designing and texture modified diet. This is the nutritional management using standards food form classification essential. We had that the view of this standardized food form is already we had that, The diet can be designed based on the IDTF framework, and sometimes the diet, the texture modified diets are insufficient in different nutrients, so sometimes we may need to fortify the food to improve the nutritional value of food in the texture modified diet, and also dietitians can be a great asset in improving the appearance and palatability of the texture modified diet. The next thing is, after doing all this designing texture modified diet and nutritional assessment and screening, we can be a good great help in nutritional goal setting and intervention, where we can provide personalized and specialized nutritional intervention by providing nutrition care plan, and we can help by using nutrient dense mixture texture modified diets which increases nutrient intake and improve nutritional status, and also they can suggest and intervene with ONS of suitable textures. So this is the dysphagic diet that we already Prabha had mentioned in our earlier presentation. So this is the detail how we formulate the dysphagic diet. So what the dietitian need to do is, besides these three different things, we can provide education and counseling to the patient, client and the family in the individual basis. And we shouldn't stop with just educating and counseling the client. We have to frequently monitor and evaluate of nutrition care plan to assess whether the people meet their nutritional needs while adhering to the prescribed texture modified diet or not, whether current measures are appropriate for the level of dysphagia and modify as needed. So we need to periodically monitor and evaluate the nutrition care plan we have provided to the patients, so that whether they are following the diet properly or not, whether their nutritional status has increased or not. So besides, we have to monitoring made by all the team members, not only dietitians. We need dietitians, speech and language therapists, which we generally lack in. So in many hospitals we do not have dietitian, and in hospitals where there is speech and language therapist, there is no dietitian. So I think we have to change the scenario. And what I want to focus is, management of dysphagia is a dynamic process. We cannot stop in one step, so which is likely to change with time rather than a static solution to a clinical problem. To sum up, there is direct interlink between dysphagia and malnutrition. So active involvement of dietitian and speech and language therapies for early diagnosis and management will ensure better outcome. It will help improve a person's nutritional status, recovery, and improve quality of life. Dietitian's role in dysphagia management is important to ensure adequate nutrition and hydration, so must be included in the multidisciplinary team as various international guidance strongly suggested. So I think most of our healthcare system has not practicing all these guidelines. So however, periodic training program is essential to update the dietitians regarding the dysphagia and different aspect of dysphagia management. So these are some of my references. Thank you very much.
Wonderful talk. Audience, any questions?
With NG2 and come to our center, NPO have had such a dramatic weight loss because the tube feedings are inadequate for nutrition. And so I love, maybe not in this setting, but sometime to discuss more about tube feeding and kind of different strategies that may work in the hall, because we find patients are coming to us so malnourished, we're already behind in their care.
Yes. Actually, we have, the main problem is in many hospitals we do not have dietitians. So that is the biggest problem. And so even if there is dietitian, there is no referral. The patients are not referred. With this conference, there will be a change.
I think activities may have started also. Whoever is having dysphagia and when they have started a minimal diet and they want to remove their NG2, I always ask them to make a chart of their food and weight and go to dietitian and take a opinion from them whether that's enough for them or not. I think that training should be done in every hospital so that no patient has to go under malnutrition and dehydration.
Actually, I had the opportunity to work with Prabha, and there was one speech and language therapist from Australia, Shan. So with her collaboration, Prabha collaborated on this, and we organized one-day workshop and hands-on training for all the dietitians with this and ITTSI. We use that, but we never have the opportunity to utilize in our practice. So that's the
taking so. Yes, a lot milk and then just put arrowroot biscuit and just mash it and give it. That is very good for the first time in care for the family.
So is there any question?
I just want to add on, there are many medical doctors.
Many hospitals, there is no dietitian. So generally, when the patient is admitted in the hospital, the attending healthcare professional, they simply ask the patient when the patient is on natural gas soup feeding. They ask to bring vegetable soup or dal soup, and which is very lacking, which is very thin, clearly about the consistency of clear liquid, which is not, which does not, which fulfills about 400 to 500 calories. So a person who will remain in hospital for 1 month, and we can see what will be the outcome.
We had a case of dysphagia, mild dysphagia with main complaint of the weight loss. So is there any protocol or that how much weight loss is much common or the normal in the period of time?
No,
Is there
actually,
any?
so that's once there shouldn't be more than 2 or 3% of weight loss. So the rapid weight loss, we have to screen the patient about the weight loss, whether it is significant or severe. So accordingly, we can do the further management.
So just the case of weight loss, so we can refer for the dietitian.
Yeah, you can. Yeah. So the first you have to refer the dietitian. She will do the thorough screening and assessment. Then accordingly, she will determine how much, what are the things he or she is lacking, and also if he is dysphagia. So first, I think if the SLP is facilities available, then first you can consult them, and with the collaboration of both of them, we can manage the patient.
Thank you.
Now I would like to welcome Ms. Sarah again for sharing your thoughts on the role of tracheostomy management.
Who's excited? One is some of the limitations that people mention about fees is that you cannot see aspiration. I think that's a bit of a misstatement because we can see pre-swallow aspiration, we can see post-swallow aspiration. During the moment of swallow, yes, there is white out, but all aspiration leaves evidence. So if you have aspiration during the swallow, when we look with the scope, we do see secretions stringing on the vocal cords, we see shininess of the vocal cords, and we see bubbling. So that's how we can say it's during the swallow aspiration, even from fees. So I just wanted to clarify that point. And then the other thing that I wanted to talk about, just 1 minute, is the EMST, the expiratory muscle strength training device. This device is commercially available. It has a lot of evidence. This one was made by our biomedical department with a 3D printer using just a click pin spring as the mechanism, and it is able to be made, and then they calibrate each one so we can go from 10 to 80 millimeters of water displaced for strengthening. So we're hoping to make this be more generally available throughout Nepal, and also to give these plans to other biomedical departments so that we have advanced technology. You know, every slide that we've been seeing, people talk about EMST, right? We want it to be available to patients because I know the commercial ones are very hard to get and also very expensive. So we're going to switch just a bit to tracheostomy care. Tracheostomy care is a team approach. It isn't something that we should be doing alone. We should be talking with our doctors. We should be talking with our nurses. We should be talking, if we have the privilege of having respiratory therapy or someone who specializes in respiratory, we should be talking with them as well about this. At our hospital, just because of my prior experience in doing lots of tracheostomy teamwork in the US, we have become kind of a trach center in Pokhara in some ways, of when people are finishing their acute care stay and needing to come for getting their trach to maybe taken out and kind of advancing their care, they come to us now. So some of the objectives, this will be pretty starting level information. We'll talk about why do we need tracheostomies. We'll talk about, oh hang on, let me change this so I can see the view better. Okay, I'll have to do here. We're going to talk about the types of trachs, we're going to talk about physiology, and then we're going to talk about kind of the process that maybe we can help someone not need a trach anymore. There are some cases that will need a trach for a long time, some of our laryngeal head and neck cancers, some of our upper airway obstructions, they will need a lifelong trach. Maybe someone who's had a high spinal cord injury who needs ventilator support for the rest of their life. These types of patients will not be able to be decannulated. However, the majority of our patients will. We'll look at a case study, and then we'll talk about upskilling, because this is not an area that most SLPs get to work in. We had a student from Australia at our hospital yesterday, and she was so excited because she'd never seen a FEES or a trach, and this is with someone who studied in Australia. So we're doing cool stuff in Nepal. Let's see if I can make this. Okay. So just a quick moment of clarification. Tracheotomy is the surgical procedure, that's the cut. Tracheostomy is the hole that the trach tube or trachea tube then goes into. So this is kind of basic, but I want us to know our terminology. You'll hear me using the term trach because I'm American. Australia and UK will say trachea. All the same term though. What are the reasons we need to do this? I had a patient in Tamsin Pampa who had been eating a donut and it was very dry, and a piece of donut got stuck in his upper airway, in his pharynx. They tried to remove this donut and could not. He had to have an emergency tracheotomy, and thankfully we were able to take the trach tube out pretty quickly after that. So that's an obstructed airway. You know, sadly we have a high cases of suicide and suicide attempts in Nepal. We see hanging injuries where we see laryngeal collapse and tracheal damage, and those patients will need a tracheostomy tube for that. Some people who have lung damage and have neuroprogressive diseases and different things will need it to clear secretions. Their lungs are not able to clear the secretions, so they need a way to do that. And then for long-term ventilation, if someone needs to be intubated and they need mechanical ventilation for a long time, a trach tube is safer than oral intubation. Okay, good. So, I'm not going to go over all that because you guys can read, and we've talked about it. There's lots of different reasons people need trachs though. Alright, do we change? So, usually 3 weeks plus is a time that people are converted from oral intubation to a trach tube. This is a non-emergent trach. This is a, maybe they've had a huge brain injury and had to have a craniotomy. We see this quite a lot in POCRA. A lot of our patients with crani have needed long-term ventilation afterwards. And so usually the 2-3 week mark is when they're converted to a trach. The reason that we convert is because trachs are easier to suction. It causes less damage. And also when you have oral intubation, where does that ET tube, endotracheal tube, have to go between? Think about your anatomy. What's happening to your vocal cords if you have an ET tube in? Are they closed or open? They're open. Good job. Somebody who was my student, I'll take it. Yeah, this tube is jammed between your vocal cords, causing damage to your vocal cords, causing them to not be able to move. So our ENTs, our doctors, we don't want that for a long time. We'd rather have it here, right? Because then you're having movement and normal structures above. You're decreasing trauma. There are so many different types of trachs. In Nepal, we are privileged that we get imports from around the world, which makes our care even more interesting because we have brands that I've never heard of before. We have brands that I'm Googling. We have Chinese brands of trachs. We have Indian brands of trachs. I've seen American brands. I can't even keep track of all the different kinds of trachs we have here. This is when Google's your best friend because you need to understand which trach your patient has because they're all different. So some of the main differences that we see are we have cuffed tubes, this first picture. Oh, I even brought one with me because we always love a practical demonstration. So there's metal ones. These are kind of our old ones. These are for usually our long-term laryngectomy kind of patients use these because then they don't have to be changed. They can just take out this piece and clean it. Right? So we have these old metal ones. We have this one's a Ramsung brand, and it's a cuffed trach. You would want a cuffed trach when your patient is on ventilation. And that's because you're trying to create a closed system. You need all of the air that you're pumping in through mechanical ventilation to go where? Out the nose? No, where? Lungs, right? You're using a ventilator for a reason, right? That patient needs the air. So you're going to inflate your cuff so that you are creating a closed system. No air is escaping anywhere, so that patient is getting that pressure that they need to breathe, right? Or to have the machine breathe for them. So we have cuff trachs. This is your first choice of a trach. And then you need to know the parts of the trach. So we have our cannula. Some trachs have an inner cannula piece that can come in and out, so for easier cleaning, right? We have our pilot line and our pilot balloon. When this is filled, it fills our cuff as well. So when there's air here, there's air here. So that's kind of how we know if the cuff is inflated or deflated by this. We have the flange. This is what sits outside of the patient's throat. And this is what holds it in place with the trach ties. So if you've never seen a trach, come up and see it, hold it, use it, touch it. Because you need to understand what's happening in your patient, right? This is in your patient's trachea. So this has changed their anatomy in a very dramatic way, right? So, different brands, just to make it even more confusing. In Nepal, I've seen 5 to 6 different brands over the past 10 years. Each brand is not created equally. Different brands have different diameters. So if I say this is a trach, this is, let's see, ooh, getting kind of old. This is a 7.5 Ramsung. A 7.5 Ramsung's inner diameter, where the air goes through, and the outer diameter that sits in the trachea has a different meaning than a Shiley 7.5 trach. So just because I say, oh, a 7.5 in this brand, I can do a 6.5 in this brand, is not true, because every trach company does sizing a little bit differently. So we're going to talk about that a little bit differently. But just things to remember as you're learning about trachs. Each one may have a different size. Some of our newer trachs also have a suction catheter above the cuff to get those aspirated materials that sit on the cuff during mechanical ventilation. That makes the outer diameter even bigger because they have to have another tube down. So when we're thinking decannulation, when we're thinking downsizing, when we're thinking airway patency, the size of your trach matters, and you need to understand the brands as well. Good, I already did that, so that's great. Physiological changes due to the trach is a closed system of respiration, right? We have valving throughout the system that opens and closes as we breathe and speak and swallow. That makes it all be different, right? I can close my mouth and I can close my velum and I can't move air. I've closed it. When I swallow, like we spoke about earlier, I have a moment that my vocal cords close and create a period of being unable to breathe, a period of apnea when I swallow, because it's a closed system. So that's considered physiological PEEP. So we can maintain pressure in our lungs because of these valves we automatically have. What happens if our ENT doctor does a great job and saves a patient's life and cuts a hole in their neck and puts in a trach? They saved their life and we're so happy. But have I gone from a closed system with valving, now this is open, right? I don't have the nasal passages to warm and humidify the air. I don't have anything blocking me from the outside. So what this can cause, and the reason that long-term trachs, while wonderful and while life-saving, the goal is to not need them as much as possible, is because we see that we lose that physiological PEEP. The alveoli start to collapse because they don't have the pressure they need. So then we see changes in lung volume. We see compromised breathing. And so an open trach is usually, I would say, it's never our aim to have an open trach. We're at least going to put our humidifier on. We're going to at least try to do a speaking valve as the patient's able. Did I do your work? Come on. I forgot. I almost forgot and kept talking. So I've asked you a movement to come up and give part of the talk for me, because she and Sunita have also done lots of competencies with me in trachs. So it's not changing her here. So we're going to talk now about cuff deflation and inflation.
Namaste everyone, and thank you, Sarana. So cuff deflation, and before talking about cuff deflation, I would like to highlight why we do the cuff deflation. And as she has already told, that reason behind the inflation of cuff is to create a closed system, to create a proper mechanical ventilation, and to make the air pass through in and through a trachea. And there are numerous risk factors associated numerous risk factors that inflation of cough can cause, and some of them are necrosis, and it's pushing toward the tracheal or posterior tracheal or valve, the inflation of cough. This is the cough. So when the cough is inflated, it pushes toward the esophageal valve and cause esophageal impingement that might lead to reflux. And if the cough is inflated, then there will be no subglottic pressure generated for the normal physiology, and that will have vastly effect on our person's swallowing ability, and no voicing, laryngeal tethering, decreased laryngeal elevation, and epiglottic excursion. So those are all the common risks that we face when you keep cough inflation for a long period. And another thing is, before we used to practice that if we keep the cough inflated for a prolonged period, then it might prevent from aspiration. But now new knowledge, new evidence shows that if when the cough is kept inflated for a long period of time, then that can cause a colonization of bacteria on top of cough, which will and there will be a lot of bacteria growth can cause, so that will be another damage in trachea. So we should deflate the cough as soon as possible, as soon as the patient is out of the mechanical ventilation, so that patient not normal but half of the normal physiology will be as when we deflate the cough soon. So this is the main thing. And after the cough we should always look for airway patency. After we deflate the cough, airway patency is the airway extends in the trachea. Is it moving or not? If there is something obstructing the trachea, maybe the mucus plus, maybe the secretion, maybe some tissue formation has happened, so that might have obstructed the trachea. And to see that, when we do a suctioning, we take us to see that what we can easily do is take a suctioning catheter and try to go inside. And when you do a suctioning, then one thing is you might feel a resistance in the trachea when you do a suctioning. So that way you can think that there is something, like maybe mucus plug, maybe secretion, maybe some tissue formation. Is the SpO2 dropped? So you have to think all of those things. And what next you can do is do a clear suctioning, and if that's not helping, maybe you push some saline, normal saline, 10 to 15 ml through a syringe inside the trachea and do suctioning again. And even if that's not helping, ask your doctor, nurses, whoever they are available, if the air is passing towards the lungs or not, and take a help of every professionals there. Maybe you can call for physiotherapists to do a chest physio. So you can think about all of those things if those complications arrive. And another thing is to check a airway patency, you can do a airway trap in black patient. It's the terminology you can use simultaneously. And what is air trapping is when you occlude the trachea with one finger, you might feel there is some pressure coming out of the trachea or from the trach tube, or maybe you might when you release the finger, you might feel some sound coming out of the trachea. So that way you can think, is there something wrong? Is the airway obstruction, maybe upper airway obstruction has happened, maybe some granuloma. So you have to think about all those things. And what you need to do in that case is maybe downsize the trach or change the trach. And you can always go for natural pharyngeal laryngoscopies to see the upper airway obstruction, to see any structural abnormalities that are present there. So after looking for those things, you can start do manual occlusion. And one thing always keep in mind is when you do a manual occlusion, you should always think that if the cough is deflated or not. If the cough is inflated, this is the cough, and if it's inflated, then there will be no passage in the trachea to maintain a airway patency, maintain a airway extent. So when you do a occlusion without looking for the cough deflation, then that might lead patient to a respiratory distress. So you should always think about that before doing trach tapping and manual occlusion. And manual occlusion is a same way when you, like I have also explained in airway, to check the airway back pressure, you do the same thing in manual occlusion as well. You keep the finger in the trach and occlude and see if the person can come. If you feel any back pressure and trapping or not, you can for that. And if the patient is tolerating well with a manual occlusion, then you might start using speaking balls, which is a and it works in a way that when inhalation of air goes through the trachea, but exhaled air will go up towards the vocal cord so that voice can be generated. But in our hospital setting, we don't have this available, and it's not so cost effective to use it in the to use it with every patient. So we directly go for a trach capping, but we're looking for to use this in our hospital as well in near future. And for the trach capping, what you do is you make a cap that fits in the trachea size, tracheostomy size that patient is having currently, and you use that cover to occlude that open space of tracheostomy. So by using that, the patient will be able to breathe in and out through the mouth and nasal passage, restoring the closed system for speech and swallowing. And in our hospital, we found it that air mold is, we use the air mold. So we take the air mold and make a cap by ourselves. Those things.
It's a creative solution to a problem we have at our hospital. So we're looking forward to communicating more with people in Kathmandu about our one-way valves and things. I was excited to hear that those are available.
So next is after you deflate the cuff, you go for you do a manual occlusion. You see if there is a trapping back pressure is there or not. Then you go for a downsizing, and yes, initially surgeons put a large size of trach to maintain, because it's a lifesaver. Lifesaver, and to maintain a proper ventilation, they put the right large size of trach. But when you think about trach downsizing, you should always look for the trachea size. You should always think about the person age, height, gender, so that you can decide which trach will be more beneficial, which will be more fit for the patient. If the trach size is large and maybe almost approach the size of trachea, then that will not have air patency. The patient will not be able to air exchange through the trachea, so that might lead to another complication, that might lead to tracheal tissue damage. So you should always keep that in mind, and as Shan has already explained that it depends, like silent trach and the cortex those are the components. So those two brands diameters, if the outer diameter is we have to differentiate, we have to keep in mind that Siley and cortex diameter is not as same. Yes.
The same, even if it's a size 6 trach and 2 brands, your inner and outer diameter will be different. So these are just things to remember as you're learning more about trachs.
So then after that, we finally think about decannulation process, which is the taking out of the trach. And before doing that, we should always think if the patient is medically stable or not, if the patient is managing their own secretion or not, how thick is secretion, the color of secretion, if the respiratory is maintained or not. You should always keep that in mind. And before decannulation, we do a trach capping. And so the standard protocol is if the patient tolerate capping of 12 to 24 hours with a maintained SpO2, then patient is ready for decannulation. So what we do is in first day we do a manual occlusion, and then you do a deflation manual occlusion. You see if there is any back pressure or not. Then you go forward. Manual occlusion, get back pressure, and you go forward.
And then we move into short capping trial, right?
Yes, short capping. First day you do a 1 hour of tracking, then you double it with each passing day. Then after the patient is able to tolerate the capping trial for 12 to 24 hours, then you take out the cap. That's how the decantation process is done. And for the stoma, site is covered with the clean dressing, and usually it heals within a week or two. So another test we can do for the swallowing while patient is in tracheostomy is blue dye test, and it's very easy to do. So blue dye is the color that we used in our demonstration video. And what you do is you will feed the patient some consistency, maybe liquid, keeping the blue dye in the liquid, and what you do is you ask the patient to swallow, and you make the suctioning catheter also ready at that time, and when patient swallow, you do a suctioning through a tracheostomy, and so that you can see if there is any blue dye occurred in secretion or not while you do the suctioning. So that way you can say if the patient aspiration occurred or not, and patient is not ready for oral diet. And but another limitation here is even if the dye is not noted, we can't be sure that patient had there is no risk of aspiration or patient might not have aspirated. There could be still a chance, and you just have missed it while you're suctioning. So you need to do further objective measure for the best standard of here. So that's all from me. Now I'd like Sarah to take over from here. Thank you.
Thank you so much, Yamuna. That was great. And I wanted Yamuna to come up and speak because when people first see trachs and when people first hear about trachs, everybody goes, it's too scary, I can't do it. Right? And that's a good reaction. You should be scared because these are medical things. Every SLP will not be competent in trachs, and that's okay. We don't all need to be. But if you're going to work in a medical setting that has trachs, the SLP is an important part of the team. None of these processes that we talked about are done by SLP alone. Of course, I'm not changing trachs myself. I'm not taking out trachs. I'm working with our medical team on that. You know, if we see something strange when we do our NPL, of course I'm calling the ENT. Of course I'm calling the nurses. This is not an independent thing that SLPs should be doing. So I want you all to hear that really carefully. But SLPs can feel competent in trach care. You know, Yamuna and Sunita are very competent now and are a huge part of the decannulation team at Green Pastures Hospital because of their skill that they've learned over the past year and a half. So just wanted to throw that out and point that out to you all as well. So let's talk about our decannulation process with one patient. It took me a while to think because we have so many different ones, but Maya Ama had a left MCA hemorrhagic CVA, and because of her need for ventilation and because of her poor oral care, she's actually the mouth I showed you earlier, they converted her to a trach quite quickly. So she came to us with a giant 7.5 well-led trach, which has one of the biggest outer diameters. It's about the same size as a normal woman's trachea, so she had no room around the edges. So we deflated the cuff. We changed her to a size 6 trach, which was a better size for her. Taking her trach out was quite traumatic. Our doctors had to pull really hard because the size 7.5 was probably quite big for her trachea size as a little old ama. She started voicing right away around that size 6 trach, and we kept seeing lots of good improvements with our manual occlusion and capping trials. Capping trials are done always with an SpO2 monitor in the finger, or if you have a board monitor. That's something else that I should have put in this presentation. When you're doing anything with trachs, your best friend is an SpO2 monitor. You really shouldn't be doing much with a trach patient if you're not monitoring their SpO2. We need to look at them physiologically. We need to look at their status, of course, as well. We need to be keeping watching the patient themselves. But also, we don't want that SpO2 to drop below 90. If that SpO2 is dropping, we need to change what we're doing because we need to protect the patient's life. Okay, the doctors didn't go to all the trouble of doing a major brain surgery, putting in a trach, keeping them on ventilation for me to not be paying attention to someone's SpO2 and then going into respiratory distress. So that's something else I should have put in the slides and I didn't. So hear it, remember it, keep that SpO2 monitor very handy. She did great. Maya Ama, she was one that we said, oh, should we follow the protocol or should we just take out her trach the next day? But we followed our protocol because that's the safer thing to do. She rapidly was able, over the course of a week, to get to 12 hours of capping, wearing the cap over without it needing to be removed. And we were able to decannulate her. Before she was even decannulated, we did a fees, and she was able to swallow well with her trach in place. So she started eating right away. Normally we'll usually take out the NG tube after the trach because of physiological things. You know, trachs make swallowing more difficult. But in her case, she just did it wild and different. She did a facial therapy for 3 weeks because of her left MCA CVA. She was discharged from our hospital 3 weeks later without a trach, without an NG tube, actually without a catheter as well, but we didn't do much with that. And she was speaking and joking with everyone. So you think about her quality of life change because then she could communicate again. She loved to tell jokes, and when she had back her voice, the whole time she kept joking with us. I can't even remember everything. She just used to have all the best jokes for us, which was great. So we gave her back a big part of her personality by taking out this trach tube, right? And that's the most important thing. So let's say you love trachs and you think, this is so cool, I want to do this too. I want to work in this setting. Well, you need to find a hospital that's going to help you train. You need to find a facility that's going to work with you, and an ENT and doctors and nurses who will let you become competent in performing tracheal suctioning. And complete a competency. Don't just do it once. Learn how to do it well so that you can feel confident. Do free continuing education courses. I think every student that I've had, they have to do these passingmuir.com courses that are free, that will teach you about anatomy and physiology and will teach you about tracheostomy and tracheotomies. And then if you have the opportunity to go on rounds in your neuro ICUs or your ENT centers, go on rounds. Think about the physiology. Think about your patients. And just get the understanding in your brain. Because once you can understand it, then the practical knowledge comes. That's it. Thanks for pushing through. I know we're all hungry for lunch.
So you mentioned how do you, when you do a two-type test, you use the track. Why didn't doing a fees is better than?
So fees is our gold standard, you're right. So if we work at a center that doesn't have fees capabilities, blue dye is your best choice before just trying feeding. And also we do the blue dye as a pre-test before we'll do a fee. So we don't want to waste the patient's time or money for a fee. So if I see gross aspiration for my blue dye test, you know, I give them a sip, I suction. I don't need to waste their rupees on the fees yet. I need to do therapy first, and then maybe the next week I need to do the fees. So that's how we use it as a pre-test at our center. But in places I worked in the US and in Nepal that did not have instrumentals, the blue dye over multiple days with multiple trials was what I used as my standard for swallowability. It wasn't the gold standard, but it was better than nothing. So that's how we use it, yeah. Thank you.
Any questions from the audience?
Question. If a patient is like frequently, if he needs a frequent suctioning, how do you determine whether the patient is ready for trial or not?
That's a great question, Probin. I should have put in some more about suction in there. Thank you for that. So what you want to look at is you're looking at, I'm sorry I forgot to put this in. This is great. Thank you for asking. Frequency of suctioning, amount of material suctioned, and it's gross, but we're looking at the color and the thickness as well. So in our nursing charts, we have every time the nurses suction, they look at those 3 factors for me. If someone's needing to be suctioned every hour and it's thick, foul-smelling, and copious, lots of it, then that patient's not ready for capping because their lungs aren't doing well enough to do it. You know, if they're only needing suction every 2 to 3 hours, 3 to 4 hours, and it's clear and scant, a small amount, then that patient is much more prepared for a capping trial or a decannulation. Yeah, so the suctioning is kind of one of those first factors you're looking at along with airway patency. You know, if they're needing suction every hour, as I'm seeing them in 15 minutes, I've already suctioned twice and it's gross. You know, tricks are gross. You know, that's when I'm gonna wait until we get better lung control. Thank you for that question, yeah.
Also Ms. Yamuna for enlightening us on tracheostomy. So now I would like to request our chairpersons to hand over token of appreciation to our speakers. I would like to call Ms. Naini Shobha to receive the token of appreciation. President of Shan and Founder Secretary of Shan, Mr. Kaviraj Khanal, who is a Chief Speech Scientist Pathologist and Audiologist at TUTH, to provide token of appreciation to our chairpersons. I'd like to call upon Ms. Prabha Dawadi to receive the token of appreciation. Thank you so much everyone for having patience.
It's me, Ankit Bhatrai, and I would like to welcome all delegates to second part of our pre-conference program. I hope you had a delightful lunch break. As we continue, our focus shifts to a new and significant topic, auditory verbal therapy. Without any delay, let's welcome our distinguished session chairperson for second part, Mr. Kaviraj Khanal and Ms. Susmita Shrestha ma'am, to take their respective seats for chairing this session. Dear guests, please join me in welcoming our first speaker, Ms. Shabnam Fatima, who is an esteemed expert in auditory rehabilitation at Medel India since 2013. Specializing in the rehabilitation of adults with hearing implant, she holds extensive experience in auditory development for both pediatric and adult cochlear implant recipients. Today, as we delve into our auditory verbal therapy session, Ms. Fatima will illuminate on the topic, encouraging auditory skill in developmental timeline. Let's join our hand and welcome Ms. Fatima. Thank you.
So for the next few minutes, I'll be talking about how we can plan a developmental goal in the area of auditory skills in pediatric cochlear implant recipients. Specifically, I'll be focusing on the key auditory development milestones and its relation to the speech development. Different goals that you can take in a developmental sequence around the areas of audition and speech perception, and also the different methods that you can use for executing these goals in therapy sessions. So before I go into the different goals, what I want you all to understand is, okay, I think this slide has gotten a bit hazy. Okay, what are the different possible outcomes that you can expect in auditory area, right? So I would like you to visualize, the first 1 year after cochlear implant, and then the second year, and then the third year. Okay. In the first year, like you can see in the slide, the auditory development is more focused on, unitary skills like discrimination, identification, or comprehension. And this the kids can do even without having integrated it with language or speech. Okay, the first 1 year completely focuses only on these skills. But in the second year, something interesting happens. And the interesting thing is the kids start integrating these different auditory skills with the memory. And what this is going to do for these children is that it's going to help them develop the auditory system processing in such a way that further development or integration with all the different areas in the brain happens. And in the third year, the focus is mainly on what we call as the auditory tuning in. Now, what is auditory tuning in? Auditory tuning in is like specifically what is happening right now. The phone is ringing, but you guys are also trying to focus hopefully on what I'm saying right now, right? So you are ignoring the phone call and the phone tune, and then you're listening to this human speech. So that development happens in the second year. And in the third year, what we call as the auditory conversations happen. And in the auditory conversations, children are specifically going to use their language skills, their speech skills through the auditory modality. And in the final year, or let's say after 4 years or something like that, children develop the ability to have an integration with speech, right? So what is this integration with speech? Is that now when I'm talking, I'm continuously monitoring what I'm saying, okay? And if I'm making a mistake, I'm trying to correct it myself, right? And this happens in a very continuous fashion. And this is because I have something called as the auditory speech loop that is very active in me, okay? And this is a skill kids will develop after 4 years. And finally, we have the cognitive language. And cognitive language is something like, again, what you guys are doing right now, you're listening to me, right? But you're also simultaneously, hopefully thinking about this topic. Okay, but there's also some kind of thought process going on behind, and you're trying to relate it to your experiences, or you're trying to think of something very distracting from what you're hearing right now, right? So that is cognitive language. So in the first stage, you guys obviously are aware of the different stages of auditory development. What are the different stages of auditory development? Awareness, discrimination, identification, and comprehension. So I'll go through each of these stages, right? So in the auditory awareness stage, the idea is the child gives us an impression that the child has heard or a sound, okay? Either has understood that a sound is present, or has understood that a sound that is supposed to be present is absent. Okay, like for example, if the clock always rings at 12 o'clock, right? And if for some reason that doesn't happen, okay, and your mind automatically goes to it. You're looking at the clock and it's 12 o'clock, but the ring has still not happened, right? So that is knowing the absence of sound, and presence of sound is just reacting to whatever you're hearing. The child here may not understand what it means, or what skills they are developing from it, but what the child knows is that I am getting a stimuli and I need to respond to it. Okay. And in the developmental sequence, in the auditory awareness stage, we are trying to cover almost the first 12 months of typical development. Okay, so you guys might have heard, right? Not kids, like even in the womb, okay, like the fetus is able to respond to sounds, okay? So the auditory development in a typically developing child is starting right from there, okay? And once the infant is born, what the child is going to be able to do in the first 12 months is try to fine tune what they are hearing. Okay, so assuming that there is continuous language stimulation for this infant. What happens is, first, whenever the child is hearing the mother or the parent or the family member talking to them, they are just going to react, okay, like for the presence or absence of sound, either by cooing or by laughing along with the mother, okay, or sometimes crying. Now, later what happens is, the child starts giving specific responses for words that are there in the language that the child is exposed to, versus a language that is very new to the infant. Okay, so this developmental sequence we are trying to cover in 4 goals. The first goal is what you call as the voice. Okay, here we want the child to respond to human voice. Okay, why human voice is because majority of the communication happens through human voice, right? So the first thing we want kids with cochlear implants to respond to is that. And then we have the environmental sounds. Now, why environmental sounds? Environmental sounds is going to give you that complete perception of an environment that you are in. Like again, taking an example of this hall. You're sitting here, you're facing in this direction, but if someone is opening the door, even without looking at it, you know that, just with the sound, that it's the sound of the door. Okay, someone is walking in, someone is walking out. So that kind of sense of the environment that you're in, we want children to develop. And then we have the speech sounds, wherein we want the child to specifically focus on responding to the link sounds, which is A, E, O, Sh, and M. And then we have something called voice in distraction. Now the idea behind this voice in distraction goal is that we want children to be able to focus on human voice even when there is a distracting stimuli or a distracting environment is present, right? So this you can do either by giving a competing noise, or if the child is focusing on something else, like say for example the child is coloring and you call out the child's name, we still want the child to respond to it, okay? So the timeline for these auditory awareness goals is around 2 weeks post switch on. Okay. And then we have the auditory discrimination. Auditory discrimination is wherein we start understanding, or the child starts understanding that 2 sounds are not the same. They might be similar in some way, but they are different in some ways. Okay. So goal-wise, what we want the child to do is, we want the child to give us different types of responses or reactions to different sounds. Okay, and in a developmental timeline, what we are trying to cover here is around the first 24 months of the child's development. Okay, in a typically developing sequence. So, and we also want the child to develop or have certain cognitive faculties, like the ability to discriminate, or the ability to make choices, or the ability to associate, and all of that. So goal-wise, we are looking at the child understanding the prosodic differences, the length differences, which starts with vocal length difference, wherein in vocal length difference you take like a continuous sound like s, or an intermittent sound like tuk tuk tuk, and a word, and we want the child to listen and discriminate. In word length differences, we want the child to discriminate different length, like a single syllable word versus a multi-syllable word versus a bisyllabic word. And in sentence length, a short sentence versus a long sentence. A short sentence where it's like mix mix versus I went to the shop. Okay. And also we want the child to give us intensity and pitch differences. And for children who are implanted late, we want them to develop the right amount of resonance to be used. So we work on the oral nasal resonance also. So the timeline for this is around 1 month to 3 months post switch on. I'll play a video and this will help you consolidate whatever you heard for the last few minutes. child is giving us consistency of less than 80%, it's considered not achieved. 80% is considered as emerging, and anything above 80% across at least 3 sets is considered as achieved in any of these goals. The next stage is the auditory segmental stage. Here the focus is going to be more on the segmental aspects of sound, and we want the child to listen to the stimuli and give us not naming but labeling kind of responses. So in labeling kind of responses, it is okay that the child listens and repeats, or kind of even points to, or even draws or writes that he has heard a particular stimuli. So in a developmental sequence, again I think we are trying to cover skills that we see in typically developing children in the first 3 years, wherein the child is specifically able to hear language or ideas around him or her and is able to respond to it in an appropriate way. Goal-wise, we are looking at sound identification and then identification of words. One thing that we change in respect to discrimination and identification of words is that in the discrimination stage, we manipulate the length of the word. In the identification stage, we keep all the items in the set with the same length. So that way the child has to start focusing on the specific segmental features or phonetic features of the word that the child is listening to. And the third goal is kind of, it's actually a goal that we take for a long period of time. And the focus here is helping the child understand the differences in minimal pairs that they see in their language. Okay, the idea is if we want the child to have a good production without articulatory errors, it's always preceded by perception. For the first 2 goals, the timeline is 6 months, whereas the third goal, wherein you are focusing on consonant only different or vowel only different minimal pairs, that's going to be like the first 2 years after cochlear implantation. You will be continuously working on it based on the child, the way the child is, presenting you with their speech production or expressive language. So this is an example of some of the minimal pairs that you can use. Consonant only different minimal pairs are only different in consonant, and vowel only different minimal pairs are different in terms of the vowel that is there in specific positions. So this again will help consolidate the idea of how to carry out linked sound not as a test but as a goal. If you have to do it as a goal, how to carry it out. auditory memory capacity of the child is not expanded, you cannot expect the child to respond to keywords when the child's auditory memory is just one item or two items. So simultaneously, you should also work on expanding the memory in a way that it is shown here. And of course, language becomes very, very important. For the child to manipulate the objects according to the sentence that the therapist is saying, the child should be knowing those concepts in language, those action words, those objects, how they are used. And as the therapist is giving the instruction, the child has to listen and follow that. Okay, that is only possible if the child has had language exposure to those specific items before. And next stage is the auditory comprehension stage. Here the idea is the child has to respond to the stimuli, but you will no longer speak about the stimuli directly. Like if you want the child to pick up the bottle, you will not say pick up the bottle, rather you will say give me something where I can pour water in. Okay, or show me something that is specifically that's white in color. Okay, so you are being very descriptive or analytical about the object, and the child has to listen and give it out. So this you can carry, and in the normal development, this is going to kind of consolidate the first 7 years of auditory development seen in typically developing children, and you can do it in various ways. One of the ways is what we call as the word play association, like what I just gave you an example of, wherein give me something to fill the water in. That is like probably a function cue. So in word play association, you're giving the different types of cues to the child for the child to consolidate all that language that they have learned as auditory language. Okay. Like there are different types of cues called as description cue. In description cue, you talk about the shape, size and color of the objects. In function cue, you talk about the function of the object. In category cue, the lexical category of the object you mentioned. Then you have the rhyming cue, the analogy cue, the attribute cue, antonyms cue, and synonyms cue. Okay? And there is second part to this, which we call as the cognitive language. I told you it's very important in the third or fourth year of auditory development. And here we want the child to be imaginative about what they have learned auditorily. So it's not just about the object that is here and now, but it's also about something probably the child has experienced before, or it's something the child is planning to experience in the future. So it's this particular set of goals is going to help the child think about what they have learned. Okay, like helping them infer or problem solve. Okay, if you are writing and your pencil broke, what will you do? Okay, you will either ask your friend, or you will use a sharpener, or you will go buy a pencil. So all this you are trying to carry out in the auditory modality, and then helping them with the higher language skills like figurative language, right? Can you give me an example of a metaphor in Nepali? Huh? Yeah. Anyone can do that. Let's see who's the sharpest here after lunch. Cheetah jaise bhaga. That is in Hindi, right? I'm just laughing. Hearing my Hindi, which is horrible. Huh?
Dog is climbing on the tree.
No. Like wo cheetah jaise bhaga. So he ran as fast like a cheetah. Okay? So something like that.
Cat just the battle.
Huh?
Cat just the battle.
Clever like a crow.
Yeah, something like that. So you're helping the child understand this. So this you will only sorry, what was that in English? That is clever as a crow. Clever as a crow, right? So so when you just, I think probably just look at it as words. The child has to know crow. The child has to know the word clever. Okay, and the words as that are there for as and all of that. So, is it enough the child knows these words to understand that clever as a crow? No. The child has to have heard someone use it in a context which meant that someone is being as clever as a crow. Right?
Like one child used to say, I am stronger than my father.
Yeah. So, yes, strength, yeah. So, using that in the context, and the child should have heard it, and you are giving in goals the opportunities for the child to hear these metaphors and this figurative language, humor, and all of that. Okay, and the final concept that I would like to touch upon is called as the theory of mind, which is a very, very important concept. Just to give you a brief of this, just look at these two pictures. There's a boy who has a mark card. He's smiling because he thinks by showing the mark card, it will make his parents happy. And then there is another child who's hiding behind a bush. Now what is common between these two is that it's not just about knowing what they are doing, they also know about others. They are trying to predict others' behaviors. In case of the first child, by showing the mark card with A+, the child feels that his or her parents will feel very, very proud of him. Okay? And in the second, the child is like under the assumption that if I hide behind this bush, the person who's playing hide and seek with me will never be able to catch me. Okay, so that is predicting others' behavior. And theory of mind as a concept is the ability to not just understand our own beliefs, but also trying to understand others' belief, like putting ourselves in others' shoes, they say, no? So that is theory of mind, and this is a concept that's very, very important for a child to, it's like almost like a precursor for the child to develop skills in school, literacy skills, social skills and things like that. In goals, there are two things that we try to develop through theory of mind. One is the mental state language, which is helping the child hear language that is not concrete. Okay, the assumption here is that with children with hearing impairment in the past, we always try to make concepts very, very visible. Okay? And what this has done is their ability to grasp abstract language has got affected, and this has been reflected by a lot of research. So we want to consciously start using abstract words with them. Can you think of some mental state words that you cannot picturize, that you cannot visualize with one picture or something like that? No? Okay, I'll give you a display. Okay? So like the word like, hope, believe, understand, decide, surprise, all these words are used in everyday language, but they are not very concrete. They are mental state words. They are words that express a person's emotional state. Okay? And another goal that we do is false belief understanding. I won't go into detail, but the idea here is for the child to understand the different perspectives that I and the child might have, or the child and the child's sibling might have, and child and the parent might have, and just giving them an idea of that. Okay? I will go out and just try to play a video that consolidates this level for you. different burst method. You saw all the videos that you saw had either the structured method, specifically the moderately structured method. So I won't show you that video for the sake of time, but I will show you the natural conversation method, which is like the most close to the typically developing children. The idea here is that children are exposed to different concepts in the same way that typically developing children are exposed to. Okay, and you're using conversations to help the child develop auditory concepts. बंदर कहाँ पे है? नानी? बंदर कहाँ है? देखो क्या कर रहे हैं बंदर? और खेल रहा है डांस के साथ नहीं? कार कार है यहाँ पे एक कार है के ओ क्या है वो हाँ मम्मा पापा दादा हाँ अभी तो दादा ने क्लास पहना हाँ मम्मा ने भी पहना है आपने पहना है नहीं आपके पास नहीं है क्लास मेरे पास भी नहीं है तो मम्मा के पास है अरे मम्मा के पास ये मम्मा के पास नहीं है ठीक है आंटी है उनके पास भी नहीं है हाँ क्या हुआ उसको ऐसे कर रहे हाँ ऐसे हाँ कुछ हुआ हाँ हुआ उसको हाँ हुआ हाँ हुआ क्या हुआ क्या उसी पे बैठे हैं हाँ आप भी बैठे हो ना हाँ क्या कर रहे हैं क्या कर रहे काम था है बॉल देख रहा है अच्छा कुकीज बना रहा है कुकी हाँ मम्मा आप खाते हो कुकीज मम्मा क्या हुआ हाँ नीचे गिर गया टूट गया हाँ मम्मा So, this natural conversation method is specifically useful for young children, but we want all children to have this structured method as well as natural conversation method. So, auditory learning is the idea that we use for natural conversation method, which reflects how we develop language in home environment. Wherein no one specifically sat with us and taught us concept, but from conversation we picked up the language that we picked up. Whereas auditory training is what we learned in school, the Nepali or the Urdu or the Hindi that we learned, wherein the specific structures were taught to us during specific period. And for younger children, it will be more of auditory learning than auditory training. And for children who are implanted after 3 years, it will be more of auditory training and then auditory learning. Okay, so that brings me to the end of my presentation. Thank you so much.
It was a very wonderful presentation. What I like the way you have given the practical, this laying sound as a goal and nicely explained. Okay. As we know, this auditory training is the foundation for the auditory verbal therapy. We all know. That's why I think many of us, we are ignoring the actually base, the foundation. Even parents, they want to jump in language rather than the auditory training. First time they come and they say, after a week or after 2 weeks, my child is not speaking even a single word. Yeah? So they don't understand the processing, whole process, like auditing awareness, and after discrimination, identification, processing. They don't understand it. So our SLP has very much important role to explain the process of language learning. Even they have processing slow, and they talk in very fast way. They have very slow. Auditory processing is very slow in the implanted children. So not very slow as compared to normal.
It needs to be developed, yeah.
Yeah, and then just I want to. My question was earlier after not seeing the auditory learning and training.
Okay.
Just I wrote here because auditory training is the last go in our method. Yes.
Yes.
But while saying we like this is the bottom up approach.
Yeah.
But in auditive verbal therapy, that is the top down approach.
Yes.
So
yes.
my mind here while saying we say auditive comprehension last we teach. But in natural way, auditive comprehension from the beginning.
Yes.
After switch on we are giving.
Yes.
This is the controversy. How we can explain this?
Sure. So younger children are because of their early or the lesser gap that they have of not listening compared to late implanted children. So whenever we talk to them in conversations and sentences, they still retain the capacity to pick vocabulary from those conversations and sentences, and they sail through all the stages that I showed you earlier, the first slide, right? Like the auditory development stage, auditory processing stage, and till the cognitive language stage, they are able to easily sail through. So you don't have to break it into small components for their auditory system to process it. But for children who are implanted late, they do not retain that capacity, or because their system, auditory system has not been active because of their severe to profound hearing loss, they need more stimulation and more specific stimulation to develop the same stages.
So you mean to say the late implanted children, Arvas method is important?
Yes, late implanted children, auditory training is more important. The structured method, the moderately structured method, or the practicing on a specific task, that is more important.
Thank you very much.
Offering invaluable insight into encouraging auditory skill in developmental timelines. Now, we are about to explore a crucial aspect of auditory rehabilitation. Our next speaker will shed light on promoting natural language and speech in children with cochlear implants. Allow me to introduce Ms. Pooja Behera, an MSc degree holder in Speech and Hearing Science from All India Institute of Speech and Hearing, Mysore, India, who brings over a decade of experience to forefront as the rehabilitation manager at Medel India. Her expertise expands over auditory rehabilitation, clinician-caregiver partnership for optimal cochlear implant outcomes, and the impact of bilingualism on cochlear implant. As well as she will also be guiding us how to use Medel intervention resources. Please join me in welcoming Ms. Pooja Behera, a distinguished professional in the field of speech and hearing, to share invaluable insight into this vital topic.
So after Shabnam's talk on developing auditory goals following a pattern, and after the discussion on auditory training and auditory learning, this gives us a perfect platform to be talking about promoting language as well as speech skills in. Now we will be discussing about some levels, the levels of expressive language, followed by some tips on how we can work on expressive language with children with cochlear implants, and a bit more. So when it comes to expressive language levels, many a times as professionals and as parents, we want the child to talk, right? We all want the child should talk. But even when it comes to talking, there are some levels that we have to follow. So the first one there being pre-speech or pre-verbal level, after which word approximations develop, after which the child starts speaking in true words, then the child joins two or more words to be able to speak connected phrases, then the child can make basic sentences and then expanded sentences. So, when a child is implanted, like I'm talking about a child who is near to the switch on age, okay, near to the switch on date, many a times it's very important that the child has some pre-verbal skills in place before the child can actually start talking. Yeah, I have seen that many times, be it professionals or parents, they try to directly jump into the verbal behaviors without actually looking in whether these pre-verbal or pre-linguistic skills are in place or not. So what are pre-verbal skills? These are a group of social communication behaviors that are used to send an intentional or purposeful message to the communication partner. Not just a non-intentional, but the interactional thing, it should have a purpose. And these might not be verbal in nature, rather may comprise of gestures or actions, eye gaze and or vocalizations. And here the core feature is that the child purposefully directs his or her attention towards the communication partner. So when I talk about the skills, you all must be familiar with all of this. Eye contact, smiling, crying, joint attention, joint activity, pointing, choice making, gestures, non-verbal imitation as well as turn taking. So imagine a child who is switched on. Always try to evaluate if the child has all these skills in place or not. When I say all, I mean all of them. Even if a single one of this is not present, that means that later on, the thing that is not present could manifest in a difficulty in the child's later stages. So now I'm going to play a video. Let's watch the video, and I love interactions when I am talking. So I'm going to ask questions. The list is there. You all have to say what behaviors the baby in the video is exhibiting. Are you okay with that? Yeah? Okay, I'll play the video. Okay, so does this baby have eye contact? Yes. Smiling, turn taking, joint attention, joint activity. Did you see pointing or choice making? No, there was no instance, so we don't know, they didn't try. Okay, so when it comes to language, interaction always precedes language. Okay, so when I say interaction, what I mean is I'm referring to this triangle out here, which means that if the child is looking at a particular object, and at the same time if the child hears the parent talk about that particular object, and then the child looks at the parent, that is what interaction is, what I mean. Okay, so in order for interaction to be developed, it is very important that the parents and the therapist use some strategies. Some of the strategies like getting face to face, meaning sitting at the level of the child so that promotes easy eye contact between the adult and the child. Shared attention, meaning talking about something that the child is interested in. Taking a lead from what the child has spoken and then following the child's lead. Imitation. By imitation here, I do not mean that the child is imitating the adult. No. What I mean is adult is imitating the child. Say for example, if the child is saying ba 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 ba, the adult is like ba 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 ba, yes, let's go and get a balloon. So the adult is imitating the vocalizations or the verbalizations of the child, and then they are imitating the child. Next is turn taking. When I say turn taking, of course it's very evident. I take a turn, child takes a turn. I take a turn, child takes a turn. That is turn taking. But what's very important is that we must match the turns. When I say match the turns, what I mean is, if the child is, let's say, saying apple, and the parent goes on like, yes, that's an apple, that's a fruit, that's red in color, we cut the fruit, we make juice out of it, we drink it. Do you think the turns are being matched? No, the child just spoke one word and the adult is speaking so much. So clearly there is a discrepancy. So when I say you have to match the turns, what I mean is, if the child says apple, the adult can say apple, take apple. And then once the child has the apple in hand, depending on what the child is saying or doing, the parent can or the therapist can say what they have thought of next. Another technique is using an interesting voice. If you talk flat to children, they will get bored. So we have to use an interesting voice with a lot of prosody, and then adapting the language to the level that meets the child's level of language. Now, I'm going to play another video. I want you all to tell me what strategies did the adult here use so that the interaction between her and the toddler was good. Okay, what level is this child in? Is the child doing vocalization to gain attention? Is he doing vocalization along with pointing, or is he doing word approximations? Are you sure? The father said waffle. Did you hear the child say something that sounds like waffle or something that sounds like pancake? Not exactly. He is vocalizing along with pointing. He is constantly saying something, and then in order to gain his father's attention, he's like, Papa, Papa, and then he's pointing. So he is not yet there in word approximation, but he is somewhere entering into that. Okay, so this is the first level. And usually this skill emerges about 1 to 3 weeks post switch on. So if a parent is coming to you and is telling you, my child hasn't started talking yet, when will my child start speaking? So keeping all the intrinsic and extrinsic factors in mind, you can tell them that if you work with your child, by 3 weeks your child can achieve some of these skills, and for this you will need to do blah 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 at home. Okay? So that's a safe answer. Then the next stage is word production, which is our favorite stage. And what is it? It is the stage wherein the child is learning to spontaneously use single true words to convey meaning, and these words could be nouns, descriptives or negatives. And if you talk about it quantitatively, it can range from about 5 to 50 words. Remember, these have to be spontaneous word productions and not word production wherein the child is repeating when you are saying something. Usually this develops about 1 to 5 months post switch on. Okay. So let's reflect, let's think, how does vocabulary grow? In a normal hearing child, how do you think vocabulary grows? Very simple. So that there are ample number of studies which say that by 1 year, the child speaks 7 plus words. By 2 years, 50 to 75 words. By 3 years, there is an increase and it goes to 1200 words and so on. Does this same thing happen even with children with hearing loss who are using appropriate hearing device technologies? What do you think? Is it same or is there a difference? There seems to be a difference. In fact, I came across this beautiful study which talks about early vocabulary development in children with bilateral cochlear implantation, and they aimed to analyze the growth of early vocabulary and its composition during the first year after CI activation and to investigate factors associated with vocabulary growth. It was shocking to find out that despite clear vocabulary growth over time, children with bilateral cochlear implants lag behind their age norms in receptive vocabulary in the first 12 months after CI activation. In the first year after CI activation, they lag in receptive vocabulary. And in expressive vocabulary, 35% of the children were able to catch up with their age norms, but 55% of them still lag behind. In the receptive and expressive vocabulary of the first 1 to 20 words, okay, analysis of different semantic category indicated that social terms constituted the highest proportion. By social terms, I mean hi, hello, good morning, namaste, all these words. And then nouns considered the highest proportion in vocabularies 101 to 400 words, and the proportion of verbs remained below 20% and the proportion of function words and adjectives remained below 10% in the vocabularies of 1 to 400 words. Why do you think? Why do you think there is this discrepancy? What does this study reflect of? Simple sentences, connected phrases, or single words? Simple sentences? How many simple sentences did you see him produce? Just one, and that was also on repetition. He is actually just speaking in true words. His comprehension is somewhere here, he is understanding everything, but maybe because I am asking him a lot of questions, he is just answering in one word. So based on this video, if I were to mark him on his skill levels, I would say that he is just producing word productions, okay, single word productions. So you have to be very careful while you are marking them across their goals. And like Shabnam said, we have to see what is the child doing with more than 80% consistency. Okay, that will give us answer to our questions. The next stage is expanded sentences, wherein this involves the usage of question forms, wherein the child is asking questions and the child is able to answer questions as well. In this particular stage, the child is expected to use sentences with appropriate word order, vocabulary and grammar. They are expected to be able to answer some simple question forms, complex question forms, and generally in this stage they use adjectives, adverbs, comparative markers. These again can be spontaneous as well as on imitation, and usually this takes about 18 to 30 months. So if a parent is coming to you and is asking, my child is switched on, when will my child be able to speak like a normal hearing child? The answer is a minimum of 18 to 30 months, keeping in mind all the other factors that are in place. Okay, this could go up or down depending on all the other factors. Okay, now let's reflect again. Why do you think children with CIs do not develop expressive language skills compared to their hearing peers despite optimal fitting, regular therapy sessions, as well as prompt parental involvement? Imagine a child that's getting proper parental involvement, they are attending regular therapy, their fitting is appropriate, still they are not able to develop that expressive language. Why? What is different? Is it that we as professionals, we are missing something? Is it that when we are coaching the parents to talk to their child naturally, are they actually talking naturally? This is something we have to think. So that brings me to a very important strategy that will promote listening and language. It's a very simple strategy. All of you know this, that is called as talk, 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 which means the more we talk to the child, the more opportunities we are giving for the child to listen and learn spoken language. And it is said that for a child to be using one particular word actively in his or her repertoire, they must have heard that word about 500 times. They must have been spoken to using such language which is equivalent to reading 10 books, and they must have received 10,000 hours of enriched language exposure. Quantitatively, the child should have received all this. Qualitatively, which is what as professionals sometimes we miss, or sometimes the parents miss, is letting the child lead and following the child's lead. Okay. How many SLPs are there in this room? All? Everyone? Okay. Some of you? Okay, fine. I'm going to give a word. Okay. I want you all to tell me some sentences about the word. Apple. Apple? Apple is red in color. Apple is tasty.
Apple is round.
Apple is round.
I like apple.
I like apple. Okay. You will never go to the doctor. Okay. So as therapists, we are always tuned to provide language the minute we see an object. As in, we go to the session with a plan in mind. Today, okay, my plan is that I have to teach the child 5 fruits name. So, okay, I will keep some apple. Okay, fine, I am a good therapist. I will not use flashcards. I will take those, you have Velcro attached, and then you sting the apple pieces and then you cut it in between. Okay, so I have those models. I am a little modern therapist. I am telling as a joke, okay? Okay, so I have those, and then I am like, I will use these to teach the child to understand and say 5 fruits names. So the minute you give the box to the child, what will the child do? Do you think the child will take the fruits and will cut it? No. What will the child do? High possibility that the child will take the apple and start throwing it like a ball. Yeah. So in that case, what will you do? No, don't do that. That is so bad. Yeah. But whereas if you were to let the child lead and follow the child's lead, what you could have said is, oh, you want to play with the apple like a ball? Come, throw the apple. Catch the apple. Throw the apple, catch the apple. Do you wanna catch half of the apple? Okay, let me cut the apple. I am throwing half of the apple at you. You throw half of the apple at me. That way, based on what the child was interested in, you are providing that language. Okay, and this is when you will be providing the child language quantitatively as well as qualitatively. Okay, and when the parent sees you doing this, they will also understand that, okay, that's fine. The child doesn't always have to listen to me. I have to listen to the child. Let me learn to listen to my child. Okay, that is when they will learn to do it. Okay, I'm going to play a video here. You all have to tell me if the mother is using the strategy talk, talk, talk properly or not. She's talking, right? She's talking so much about the bangle, about the box, about the boa. She is following talk, talk, talk technique. Is the child following her? Nah, child is not interested. So what has happened? What has happened is that the therapist has forgotten to tell the parent that the prerequisite of talk, talk, talk technique is have the child's attention first and do or talk about what the child is interested in me. So that way, the strategies which we were talking about in pre-verbal communication, joint attention, joint activity, that is taken care of, and that lays the foundation of teaching language to the child, and that is when the child will be able to learn more from what the parent is talking. So talk doesn't mean that we talk about what we have pre-planned in our head while the child is looking at or is interested in something else. So we have to remember that we need to provide them the language that they need. We have to provide them the language that they need, not the language that we have planned. Okay? Okay, so now this mother was coached about the pre-verbal strategies. So now you can see that she has come down to the child's physical height. So she is at the child's level. And then let's see what else is she doing and how that is impacting the child's communication behaviors.
क्या है ये? बॉल खाते हैं इसको, खेलते हैं, पागल बॉल है, बॉल जैसे आपके पास बहुत सारी बॉल है। और ये कैट है, और ये देखो ये बॉल ये बॉल, और ये एलिफेंट है ना? हाँ, वो हाथी है। ये देख बाबू ये मछली जल की रानी है, ये देख मछली जल की रानी है ना? और क्या देखेगा मेरा सोना, और क्या देखेगा, और क्या देखेगा, क्या 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 देखेगा बता, क्या? मम्मा खोले इसको, ये देखो, लोहन है, ऐसे बोलता है। और ये monkey 5 little monkey, हाँ क्या तो alphabets हैं, हाँ भाई इसमें क्या पढ़ोगे, ABCD, हाँ ये पढ़ोगे, अच्छा और ये zebra.
Okay, did you see any change in the child's behavior? Yes, there were so many positive changes. The child has started vocalizing. He is looking at the mother. He is being a child. He is flipping the pages, which is okay. But still, the mother doesn't feel that, oh, okay, my child is flipping the pages. My child is not listening to me. I have failed. No, that is not there. She is in fact content. She knows that whatever I am going to talk to the child will listen. And can you guess the duration between this video and the previous video? What do you think? What is the duration? How many sessions should have happened in between? 0. That session, the tip was given. The next session, this is the video that she sent. So when you give them the right message, they have it in them, they will be able to develop the skills. Parents aren't always that bad after all. Yeah? Okay. So what is missing is the absolute conviction that the child can listen, understand and talk. Sometimes we as professionals, we are like, what do I talk with this child? Will this child actually listen? No, that's okay. Let me go the bottom up way. Yeah? Or sometimes we wait too long for expressive language skills to emerge. Because we have been taught that first audition will develop, then receptive language will develop, then expressive language will develop, then speech will develop. Yeah, have you learned it like this? But no one told us what is the duration between these. Okay, so there is a very probability that all these 4 skills can develop parallelly, and we do not have to wait for too long. Chalo, let's keep on take therapy for 2 years, my child will start talking after 2 years. No, we don't have to wait that long. Thirdly, sometimes we do not provide enough wait time for the child to take turn and initiate an interaction. We are like impatient. I want to say something, I want the child to repeat, child doesn't repeat, I will move on to the next sentence, child will not repeat, I will move on to the next sentence and so on. So the child is not getting an opportunity to participate in the conversation. Which is why the child thinks that, okay, my role in this conversation is just to sit and listen. It is okay if I just sit, listen, understand and point to things. The child hasn't yet understood that it is also his responsibility to start to talk. Okay, so we have to show that to them. Sometimes we do not acknowledge their small wins. Like if the child just says, that is also a big thing. This child was not vocalizing. Now if the child is saying, Yes, you are saying, good job, something like that. Acknowledge their small wins. Sometimes we do not appreciate ourselves as well as the parents for the small wins. If the child was not vocalizing, and today in the session the child has vocalized, who do you think the credit should be given to? To you all and to the parents. So learn to appreciate yourself, and yeah, that will go. Remember this, for child initiate conversations, the first rule is that the child always initiates the interaction. Meaning, if you give a toy to the child, you have to observe the child, wait and see what is the child doing with the toy. Okay, if the child is, let's say, playing, you can keep on talking, but go down to the child's toy level, see if the child is maintaining an eye contact with you, see if the child wants you to be a part of that play. Once the child wants you to be a part of that play, follow the child's lead by imitating. You could imitate what the child is doing, or you could comment, oh, you're playing with the ball, or you can interpret, oh, the ball is stuck, you want to break the ball, and then look at the child expectantly again, so that the child again says or does something which lays the foundation of you taking another turn of talking. So these 4 steps have to be there in a cyclic manner, only then the interaction will be complete between you and the child. So, how do we facilitate speech on demand? By speech, I mean articulation here, okay? Up till now, we have just spoken about language. Now, I am shifting gears and going to articulation. We have to encourage children to vocalize from early days. This sets an expectation that the child, for the child, that they can speak. And then encouraging and facilitating repetitions, that is, some word approximations through play-based activity. We have to reinforce when they take any vocal turns, and we have to be playful and not be the usual, I will give you the toy only when you talk. No, not that. Okay, I have a small video for that. Let's watch that. She said, go Phoebe. Okay, so this video was shot when the child had completed 1 month post switch on. So she has just been switched on. She didn't even have her follow-up fittings yet. Did you see that the child was so happy taking turns in trying to repeat the sounds? She was happy. While the child was repeating the sound, did any one of you look at the mother's face? No? Okay. The mother was smiling. She was also happy and content that, okay, somewhere something is going right. So as professionals, Let's pledge today that we will help the families leave the sessions with a feeling of happiness and success, not a feeling of failure and oh my child doesn't do this, blah 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 blah. Blah. No, we have to give them happiness and success because we care. Okay? So that brings me to the end of my first presentation on promoting language and speech. Over to you.
Thank you very much, Pooja. First of all, I'm very happy that you talk about the natural language and speech development. Like as you said, most of us are like, first of all, thinking that when my child will be speaking. And also we are giving input to the child with very limited thing, like we are being conscious, let's say. We are being conscious and giving the input to the child and expecting that the child will speak, the child will speak. In fact, we should be very open and talk naturally, and let's not think that my child will not understand if I speak or not. It will be very difficult for the child if I talk in a very long sentences or in a complex way. Let's talk naturally and develop the language. Thank you very much for this enlightenment.
Thank you very much for this presentation. Really here you have highlighted the importance of pre-implant therapy. Usually in pre-implant therapy we work on pre-linguistic skill, pre-verbal skill, because without improving child pre-verbal skill, we are not going to learn the language, as we saw in one video. Another thing is that we have to use right strategy in the right time, the right place. That is also very much important. Like the child was moving and she was just pulling the child and he was not interested. So always important, follow the lead. That is technique which is very much important while giving auditive verbal therapy. And natural language means we have to modify. Natural means just not like your grandfather or mother they are talking in a way, but little bit modification is important. Once we explain to the parents about the modification, using the varying that intonation, madrish and stress and even other pre-linguistic skill, and definitely child will learn. I have one child now just after 2 months, when I got surprised. In 2 months I is taking 3-word phrases. Can you believe that? After post-revision.
That's nice.
Really. And then I asked father, mother is also not there. I asked father, how you are teaching at home, what I am explaining everyday activities and all. Just whatever you are telling, I am doing that. I think he is doing more than I explained. Thank you very much.
Just told that we should use child-led session. So we should use child-led session in cochlear implant. Is it practically possible for a therapist to use child-led session in cochlear implant recipient?
Yes, I'm not saying child-led session, I'm saying child-led interactions. Meaning, if let's say, tell me one activity, tell me your favorite activity that you want to do.
Child?
Yeah, any of your favorite activity.
I request, I teach child landing, that is Deru, I say child Deru.
Okay, you want the child to ask you for something. What they should ask for? You have some toys?
Yes, their favorite toys like Precons.
So playing seems like your favorite activity, right? Okay, so if I were to do a child-led activity with the toys, what I would do is I will not keep the toys to myself. I will give 4 or 5 toys to the child and I will see what the child is doing with the toys. Say for example, I'm scared to touch anything on this table. Okay, say for example, let's imagine this is a bus and the child lifted the bus and then the child is just looking, oh, you're looking at the bus. I will go down to the child's level and I will, oh, do you want to give me the bus? Do. And then I will ask the child to give it to me. If the child gives it to me, oh, see, I think there is a dent here. What do we do now? Show the child a dent. Get your child's interest there and then you talk about it. And then if the child wants to take it, you can say, okay, can you try saying do? So there is a difference between doing, like the child dictating your session by sabotaging everything that you have planned, and the child still being in the plan that you have planned but is only initiating the interaction. I am saying keep the interactions child led. I am not saying keep the goals child led. Goals have to be led by the therapist and the parent only. Interactions have to be led by the child so that the child is interested in doing the activity that you have planned. Otherwise, the child will run away. Many a times children don't want to do the activity because they are not interested in that. So there's a difference. That's the difference. Thank you.
Thank you very much. Any question?
Okay, I'm going to do one thing. I will be presenting about some medal resources there. There in the presentation, I have a list of activities that one can do at home and in therapy sessions. So if after seeing the activities also, if your question is not answered, can I answer you after that? Remember to ask this question again if it is not answered. Sorry.
Thank you, Ms. Pooja Behera. Now I would like to invite our session chairman, Mr. Kaviraj Khanal sir, and Ms. Susmita Shrestha ma'am to kindly present a token of appreciation as a gesture of our gratitude for Ms. Shabnam Fatima and Ms. Pooja Behera in valuable insight and expertise in this field. I would also like to invite Ms. Pooja Behera to receive the honor. Ma'am, to kindly present token of appreciation to our esteemed session chairperson, Mr. Kaviraj Khanal sir and Ms. Susmita Shrestha ma'am.
I'm really proud to say that in MEDAL we have rehabilitation resources catering to assessment, intervention tools. We have presence on digital platforms as well as social media. And if you ask me what is the go-to document where you can find the names of all the rehabilitation resources that we have, that is the Bible. So that is called as the MEDAL Rehabilitation Catalog. So this catalog has the name and summary of all the rehabilitation resources that we have in MEDAL. Many of these are free downloads. Some of these are not free downloads, but if you want to procure them, you can just get in touch with your team here, or you can get in touch with us and we'll be happy to share these with you all. So how do you access these resources? You can find these resources in the MEDAL website. You have to go to the MEDAL website, go to support section, then go to the rehabilitation section, and then go to the downloads. You'll be able to see the list of downloads. You can find our apps in Apple App Store and Google Play Store. You can subscribe to the MEDAL blog called as MEDAL Here blog, which is blog.medal.com. This particular blog was initially designed for users and parents, but then to be honest, I as a professional also find these blogs very useful because these are small and concise in nature. They give quick tips and tricks that I might want to implement in my day-to-day practice. So I will really encourage you all to subscribe to the Here blog and read some of the blogs that come up. So these blogs are in 3 categories. First is audiology blog, then is rehabilitation related tips and tricks, and then there are some guest articles which are written by our users and their families. So these are really motivational. Then we have something called as MEDAL Professional blog, which you must subscribe for. Why? Because there is a surgical section here, an audiological section here, as well as a rehabilitation section here. And in the rehabilitation section, you get lesson plans for different age recipients. We have for babies, we have for children, we have for adults, we have resources for music and much more. So if you subscribe to these blogs, then these lesson plans will automatically keep coming onto your inbox if we come up with something new. If you want to explore what was already published in the past, then you have to go to the professional blog and then visit the section and download it. These are wonderful tools, I must say. You must use them. Then we have Medal's YouTube channel, and of course you can get in touch with Medal local representatives if you want some of the resources, or you can directly email us and we will be happy to send some of the resources to your center. Okay, so the first tool that I want to talk today about is the Little Ears Auditory Questionnaire. How many of you have heard about this thing? No? Okay. Okay, some of you have heard. Okay, so the Little Ears Auditory Questionnaire assesses auditory behavior in children up to 24 months of age. Okay, this is a parental questionnaire. So the parent needs to sit with the therapist and fill this. Very easy. It comprises of 35 yes/no questions, and these cover things like reception, comprehension, and a little bit of speech production also. And in the end, depending on how many yeses and how many no's the parent said, you will get a score. Okay, so that score can be plotted. Can you see this graph here? Yeah, so that score can be plotted on the y-axis, the vertical axis, and hearing age of the child can be plotted on the horizontal axis or the x-axis. So this dark black curve here, that represents typically developing curve. So a child who is typically hearing will have his scores here. Between this to this, if the scores are falling, that means the child is developing auditorily, the child is getting some auditory benefit, but there is still some scope of improvement. However, if the child's scores are falling in this blue shaded area, which means the child is not getting auditory benefit. This is the time you have to talk to the audiologist, talk to the surgeon, you have to talk to the parents, and you have to assess and see why exactly is this child not developing auditorily. A really quick tool to administer, and yeah, if you want, you can get in touch with us. We would love to send this to you. So this is how it looks like. So it has a manual, and then it has the scoring sheet and the graph. So that was for children less than 2 years of age. So if you have children who are more than 2 years of age, within 0 to 6 years, then we have something called as a child's journey, which is available as a booklet format, which I'm sure Sushmita will have a copy of. Usually it is used to assess a child on an annual basis, and you can pick the goals from there. Okay. A shorter version of that is called as a child's journey parent checklist, which has 3 domains. So the booklet version has 8 domains: audition, receptive language, expressive language, play, literacy, and some other skills. Okay. Whereas parent checklist has audition, expressive language, and speech. A quick version to be used for 0 to 6 years of age. Then we have something called as building blocks of speech. I really love this tool because this is a one-page tool. On one side there are sounds of English language, like by what age what sounds emerge and the age in which the phonological processes are suppressed. On the back side of it, there are the format frequencies of all these sounds. So the front side of it can be used by the therapist to work on production. The back side of it can be used by the audiologist to see whether their mapping is giving the child the optimal access to all the sounds that the child should be hearing. Okay, so this is a wonderful tool available as a free download. In fact, if you're students, I will really recommend that you have a copy of this in your with yourself and then use it and see if you like it. So this helps analyze auditory discrimination, articulation, and phonological skills in children with hearing loss. Then we have something very interesting called as the hearing posters. These are 4 in numbers. These are basically meant as posters that can be stuck in walls in clinics. But if you are students, or if you are a clinician who doesn't want to paste the posters but prefers having the printouts as you know, like a paper format, you can just take a color printout or a black and white printout, keep it underneath your tabletop, usually the wooden top with a glass thing, use it as a cheat sheet. So what this has is, there are 2 for children and 2 for adults. Okay. So the first one for children talks about some useful strategies that the therapist and the parent can use with the child. So it's like a reminder. It's like a reminder on our face to use the strategies. Okay, so have it handy. The second one is on some tips that you as therapists need to follow if the child is going to a classroom. So again, like a reminder of what are classroom modifications the child might need in school so that the child is able to perform better in school. So these are the 2 for children. And then there are 2 for adults. One is for their communication partner, as in what all the communication partner need to do so that to ease communication with this adult. The second one is on some self-advocacy skills. Okay, so 4 wonderful free downloads. These are 4-page documents. You can download it and you can use it. Then this is also a free download. We have something called as My Little Year's Diary. What do you think this is? It's a diary. It's a diary that the parent can use to document weekly progress in their child. So this has 5 parts. It has My Diary. Then it has a parent book which a parent can refer to see if their child is progressing okay or not. It has a first words list wherein they can write down the words when the child starts speaking. It has a therapist book which the therapist can see as a guideline, and then it has some overview sheets. So this is how it looks like. So here you can see week 1, and then there are prompts for questions that the parents can fill in. So for example, one question is, what was the most important observation for you this week? So we want the parent to be filling out this information. Many a times the parent might not know what exactly to look in that particular week. So there are some prompts here, like you might observe these things in your child, please observe. So based on what they observe, they have to write it down. And then the next question goes like, how does your child react when you put on the device or when you remove the device? How does your child respond to sounds of different loudness? So if a parent is filling this on a weekly basis, what is the advantage? It will help the therapist plan their goals in a way that is suiting the family's needs. Okay, because we as therapists, we just know what is happening in the therapy sessions. Many a times we might not know what exactly is happening in their house. So if you want to have an idea of that, then you might want to ask the parents to fill in this. So this is how the first word list looks like. There is lexical categories, the heading, and then my child understands. There is a column for what my child understands, a column for what my child says, and the target word. So in India, finding vocabulary tests in all the Indian languages is a challenge. Is it a challenge even in Nepal?
Few places.
Yeah. Do you have like a formal vocabulary test?
No, I think we have Nevari, Nepal.
Okay.
But one maybe the plain area.
Okay. So if testing vocabulary is difficult for you because of many languages, many dialects, you can consider using this. So what will happen is, this is just a template and then blank spaces. So when the child, let's say, consistently understands that's a bottle and is saying bota, so you are writing child understands bottle is saying bota for bottle. Okay, so this will give an idea to the therapist as to how the child's vocabulary is developing. This is just the first section, so this has sound effects and animal sounds, but this goes up till verbs, adjectives, adverbs, prepositions, and much more. And then after maybe 6 months of having filled this, you can count the vocabulary and see if the growth pattern follows the developmental curve that is there. Okay, so this is kind of like an informal way of assessing the vocabulary growth in children. Along with this, there is something called as Little Years Diary Activities, which gives you weekly activities which you can do in your sessions and the families can do at home. So this gives the date, it lists the things that you will need to do an activity and then the activity. Okay. These activities are there for 28 weeks. Some of these activities will feel that they are too Western. So in that case, we are smart enough to adapt. Let's say for example, the activity says like making cookie with the child. You can change the cookie to making momo with the child. Yeah, we just have to learn how to adapt it. The idea behind this is to adapt it, use it, and then see how the parent and the child communicate. Okay, and once the parent and the child are communicating, you have to ask for their video, or you can even video record yourself and then rate yourself and the parent on this particular rating scale called as family interaction rating scale. That will help you see the way you are coaching the parent. Is the parent picking up the skills or not? Say for example, if you are teaching the parent to be sensitive towards the child, and then in the video you are saying that the parent is just hitting the child. So you know that the parent has not learned it. And you can't say, oh, this parent is bad, the parent just keeps on hitting. Who has failed? I have failed as a therapist. Okay. So this is again a free download. Download it, use it. In my initial years of training, I have used this particular rating scale to rate my own videos. Okay, so if you want, you can use this even for your videos. Okay, some clinicians told us that the activities in the previous daily activities were too Western, so we came up with a list of 101 Indian activities for caregiver-child interaction. So this is a list of 101 activities that the parent can do with the child at home, or you as therapist, you can have some props and do these activities at in your session with the child. Okay, these are 101 activities based on daily routines, home-based activities, festivals, play, books, and so many other things. If in fact I will do one thing, I will email a copy of this to Sushmita and then she can maybe circulate with you all. Even though this says Indian activities, I am sure most of them can be used in Nepal as well. Okay? And then yes, I encourage you all to again head to our website and have a look at all the downloadable resources that we have. 70% of our resources are available as free downloads. So I will say that download them and use them, and the remaining 30% you can get in touch with us and we'll be happy to share them with you. So this is how you can reach us. You can write to rehabilitation.india@medal.com, subscribe to our blogs, visit our website, and there you can find us. Thank you for listening patiently.
Thank you, Pooja, for highlighting the intervention resources. I think assessment opened the door of intervention. Yes, that's why assessment is very much important. Without assessment, we can go ahead. Most of the materials which you have highlighted are really important. I have seen, but you people have not seen. Maybe in future, we'll try to translate. Not we'll try, but we will translate in Nepali language also. So in future we'll be working for that. So then we'll have one language with some materials and little years and other materials. Thank you very much.
Thank you.
Suppose you have a child with bilateral severe profound hearing loss, fitted with CI, has come to you, and you started therapy, and then over the time you realize that he falls into autism spectrum as well, so he has a comorbid condition. How does your therapy differ? How would you plan for that child? Anybody can answer that.
Strategies that you use with pediatric recipients individually and with autism spectrum children. Okay. But significantly, what I've seen is that initiating that conversation that Pooja was talking about, initiating the child-led sessions become a little tricky. The children who, have this comorbidity. And so if in children with cochlear implants, that takes like, say 1 session or 1 week, the children with comorbidity of autism spectrum disorder might take 1 to 6 months to resolve that initiation in communication and child leading the interactions. So that might take, one of the things that I do, because I'm trained in picture exchange communication system as well, so I use that system to initiate the conversations with these children. You have to even make communication and language activities very structured for them. Whereas a child without the comorbidity, you don't have to, you might just follow the conversation method. But for autism comorbidity, you have to even break down all the pre-language skills, and you need to work on that. So
Yeah, so like my second question is, so I have been seeing this child, his switch on was done 6 months back, okay? So now he's coming to therapy, and after 6 months he's slowly learned to vocalize. It's been 1 week honestly that he's learning to do that, and you can understand the frustration the parents are having, because right, so should I continue that, or should I also start working on AAC, right? Should I focus only on AVT and speech and language part, or should I also start working on AAC? How do we balance that honestly?
I would recommend using picture exchange communication, for example, right from the beginning, because like I said, that in order for you to build up on words, the child needs to have prelingual behaviors, which is what is significantly absent in this group. So what is the harm in introducing an AAC system that you can later kind of wean off if you want? Pooja has.
Yeah, I just want to add, when we are implanting a child, what is our primary expectation? That the child should communicate. If the child needs AAC along with AVT, along with PECs, along with something else to be able to communicate, why not use it? I think just because the child has been implanted, we cannot punish the child saying that, you have to do AVT only, despite knowing that that is failing. And having said that, I am not saying that you have to stop working on audition goals. You still have to work on audition goals. Maybe the goals will not grow vertically, maybe they will grow horizontally. Like within the domain of discrimination, see what all can you teach the child, what all can you teach the parent. And then through AAC, make the child vocalize, use some words, use some pointings, and get some communication skills placed in the child. Maybe that will aid the child to develop some identification abilities also, and they can go together.
For your enlightening presentation. Your expertise and insight will illuminate the path toward better auditory rehabilitation. Now, as we are about to conclude this session, I extend my sincere thanks to all of our distinguished speakers for sharing their expertise. Similarly, I would also like to give heartfelt appreciation to our session chairpersons. Your active participation and thoughtful engagement have made this session truly enriching. Thank you all for being part of this insightful exploration into these crucial topics. We look forward to seeing you on conference day tomorrow. Safe travels and have a wonderful day ahead. Thank you.
Thank you, Ankit.
Krishna, please be seated here. You have to back up all of these things. Thank you.